بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. Today we have a session for chest imaging. We are greatly thankful to our great Professor Dr. Yosryah Sabry, head of chest imaging at Qasr Al-Aini, Cairo University. Thank you very much, Dr. Yosryah, for participating with us for this, inshallah, very nice and very useful lectures. You can start now, Dr. Yosryah.
هنعمل الشير سكرين. To start with, I would like to thank Professor Hisham Sheikh for arranging this lecture, and I would thank all my dear colleagues who have shared in it in the previous sessions. النهارده بإذن الله هنتكلم. The course is about an introduction to pulmonary imaging, how to approach. وزي ما حضراتكم عارفين, I'm Professor Yosryah Yahya Sabry, Professor of Thoracic Imaging, Qasr Al-Aini, Cairo University. Objectives. To start with, after the course, the attendant should know the following: A, quick anatomy review, normal variants, focal and multifocal well-defined lung lesions, fibrosis, consolidation, collapse, opaque hemithorax, hyperlucent hemithorax, chronic diffuse infiltrative lung disease, airway disease, and pleural lesions. Pleural lesions that we're going to discuss is effusion, pneumothorax, hydropneumothorax, malignant pleural lesions, fibrosis, and calcification. Now, to start with, we're going to go through a quick anatomy review. Anatomy is a main tool for radiologist. مش حاجة خدها وامتحن فيها وخلاص, ده يعني it's one of the main tools. To start, we have this chest X-ray PA view. الchest X-ray PA view ده عندنا ممكن أوصف الليجن zonal wise, which is an easy way. ده الأبر ده الفيرست ريب anterior part بتاعه. أول 2 ribs ده upper zone, من 2 ل 4 ribs anterior, this is the middle zone. Below the 4th rib anterior, this is the lower zone. على الرايت وعلى الليفت نفس الكلام. في طريقة تانية لوصف الليجنز, Lobar. The upper lobes, على الupper lobes على الناحيتين. عندنا بمنتهى البساطة, this is the hilum, extending a line from the center of the hilum peripherally. Okay, what is above this line here is a triangle on both sides. It's presenting the upper loop. And from this line, we have another triangle. We will join the tip of this line to the cardiophrenic angle, and having the cardiac border, we have another triangle. On the right side, we present the middle loop, mirror image of this, what we have just described. On the left side, we have the upper loop, and we have the lingual. Going to segmental anatomy, in the upper lobe we have عندنا 3 segments, triangular again in appearance, with the apex at the hilum and the base periphery. Apical segment is apically. Below it we have the posterior segment, وعندنا the anterior segment standing on the line that we have, the imaginary line that we have drawn. On the left side we have an apico-posterior segment in this position, and we have an anterior segment in this position. Regarding the middle lobe, below the imaginary line, we have the lateral segment, and related to the right border of the heart, we have the medial segment of middle lobe. On the other side, we have the superior segment below the imaginary line of lingula, and we have the inferior segment of lingua related to the left cardiac border. بالنسبة للlower lobe. اللور لوب posterior للستراكشر دي، بس في طبعا في الchest X-ray superimposed. عندنا الapical of lower nearly at the level of the hilum on both sides. the lateral basal segment موجودة في الposophrenic angle. عندنا في الازايجواسوفيجيال recess في الميديال basal segment which will be mostly below behind the heart, while on the left side behind the heart we have the posterior basal segment. The posterior basal segment of the right lower lobe is beside the medial basal here, and the rest of the lower lobe is mostly this anterior basal segment. What about the lateral film? Main indication of lateral film is to localize a lesion, confirm the presence and to localize the lesion. من الحاجات اللي يعني في بعض الناس بتبقى يعني بتحب تسأل عليها قوي حكاية the right lateral left lateral. Actually the routine lateral that should be done زي ال PA is routine. الروتين lateral is a left lateral. طب أعرف منين right lateral left lateral والكلام ده؟ في حاجات كتيرة، بس أنا the easiest way is أول حاجة I identify the cupula. The cupula that I can see all through لحد قدام, this is the right cupula. The cupula that is obscured by the heart is anterior, this is the left cupula. So this is the right cupula and this is the left cupula. بشوف مين فيهم أعلى ورا. هنا الليفت أعلى ورا يبقى ده left lateral، هنا الرايت أعلى ورا this is the right lateral cupula. This is the easiest way to identify which lateral is this. Sometimes actually it's very difficult, but يعني if they can be seen separately you can identify it. Quick review بقى للCT anatomy. طبعا الاناتومي بتاع اللنج بنبص عليه في اللنج ويند، بس عندنا 2 لاند ماركس مهمين جدا في الميدياستاينم بتخليني اقدر اعرف الليفل بتاعي. اللاند مارك الاولانيه ان انا اشوف الايرواي البلاك اللي موجود في الميدياستاينم. طول ما انا شايفه ايرواي في الميدياستاينم I'm having upper lobes on both sides. الابر لوب فوق خالص في الكاتس الفوقانيه خالص are apical segment. Then I have بعد كده عندي upper lobe anterior segment, anteriorly, posterior segment, posterior, and an apical segment in the middle. While on the left, anterior segment and apico-posterior segment. Right. Then we have the fissures. بعد كده few levels, a few cuts later, we have the major fissure appear. Once we have the major fissure, بقى عندنا apical of lower on both sides. Once we have apical of lower, we no more have apical of upper. هيبقى عندنا anterior, posterior, major fissure and apical of lower، وهنا anterior وهو السيجمنت هنا اسمها apico-posterior. تمام. وبعدين apical of lower. خلصنا الايرواي، يبقى خلصنا الابر لوبس. عندنا ميدل لوب اهو هنا اهو، ادي الكونفيجريشن الراوندد configuration of the heart. على طول بقى عندي هنا anterior, this is the middle lobe, and here we have the lingula. The medial of middle is the segment beside the heart, and the inferior of lingula is the segment here beside the heart. Behind the fissure, ورا الفيشر major fissure بقى عندنا البيزل segments of lobe, which are very easy to know. anterior basal هتبقى قدام، والposterior basal هتبقى ورا، والmedial basal in the azygoesophageal recess. Here we have the anterior basal and the posterior basal. طب where is the lateral basal? We have said من ال PA film ان اللاترال بيزل موجوده في البلورال ريسيس، فهتبقى تحت شويه، هتبقى اول ما يبان البلورال ريسيسز هيبقى عندنا هنا anterior basal, posterior basal, medial, lateral basal اهي بتبتدي تبان تحت، وهنا عندنا anterior basal, posterior basal and lateral basal. يبقى اللاند ماركس بتاعتي هي الايرواي والكونفيجريشن بتاع الهارت. نكمل بعد كده. This is a normal HRCT in a 35-year-old female patient. هنا مهم قوي نبص على التراكيا. التراكيا configuration, if I have a rounded or oval trachea, this is an inspiratory phase. This is a proper CT. يبقى أول حاجة عشان أعرف inspiratory phase، لأن الإكسبيريشن والبتاع بيبقى فيه fallacies في الدايجنوز. الحاجة الثانية I should compare the lucency of the trachea to that of the lung. Both are black, but there is a discrepancy in the blackness. لو اللنج نفس اللوسنسي بتاع التراكيا this means I'm having a hyperlucent lung. ده في الهارزوش. طيب بعد كده الفيشرز مهم جدا، ده conventional CT study. الميجر فيشر بيبان كباند of avascularity, while the minor fissure will show as an area of avascularity. في حين ال high resolution where we take very thin sections of less than 2 millimeter, we will see the fissure as a line. If you don't see the fissure, this is not a high resolution. تمام؟ ده high resolution معمول volumetric study. تمام؟ وبالتالي بنعمل reconstruction بنفس الجودة، بيبقى عندنا ده الماينور فيشر وده الميجور فيشر. في طريقة تانية لعمل الهاي ريزوليوشن ان انا باخد اكزيال ثين كات ايمجز، دي برضو اهو الفيشر بان، فده هاي ريزوليوشن، بس المشكلة انه بيبقى الصورة ليتل بيت نويزي وبتبقى فيه some diagnostic problem especially في النودولز. بعد كده الفاريانت، ذا كومنست فاريانت اللي احنا بنلتقي بيه هو الازايجوس لوب فيشر زي ما حضراتكم بتشوفوه ده منظره في البلين فيلم وده منظره في السي تي. other uncommon variants ممكن بتتشاف في الريكونستراكتد ايمجز بالذات، ده السوبيريور اكسسوري فيشر كاكزامبل اللي هو بيفصل الميديا السوبيريور او الابيكال سيجمنت اوف لور من البيزل. نبتدي بقى نابروتش اللونج ليجنز. الدخله بتاعتنا اللونج ليجن is a practical approach meaning I'm not going to say congenital traumatic inflammatory مش عارفه ايه، لا، لما بتبص على فيلم او حاله ما بتطلعش تقول لك انا congenital ولا inflammatory، بتشوف ليجن وبتبتدي تفكر الليجن ده possibilities بتاعته. فاحنا هنابروتش ليجن وايز. اول حاجه focal and multifocal lesion. I'm seeing a focal or multifocal lesion. طيب الليجن اللي احنا هنتكلم عليه we're going to describe now, we're going to discuss اللي في دماغنا دلوقتي انه I'm discussing a well-defined lesion. Well-defined lesion اللي we are approaching is I'm dealing with a circle, I'm dealing with a round lesion. well-defined اللي هنبتدي بيه هي well-defined opacity lesion أبيض and rounded. If it's more than 3 centimeter I'm discussing a mass, less than 3 centimeter I'm discussing a nodule, millimetric I'm discussing a micronodule. A millimetric هنا I mean about 3 to 7 millimeters تقريبا. طيب to start with the male يعني ايه الابروتش بعد كده؟ خلاص لقينا ان انا عندي well defined lesion. اول حاجه بشوف السايز، ثاني حاجه البيشنت نفسه، الايدج مهم جدا في الايدج والجندر والكلام ده بيهمني جدا في ان انا ابروسيد بعد كده افكر في الديفرنشال دايجنوز. المورفولوجي اوف ليجن زي ما هنيجي دلوقتي، المورفولوجي اوف ليجن في اللانج ويندو او في الاكس راي، التيشو كاركترايزيشن وده بيستدعي ان انا ابص على ميدياستاينال ويندو في السي تي. طيب let us proceed. اول حاجه ادي الليجن في اماس ليجن في الليفت ابر زون او ممكن نقول ان عندنا في الليفت ابر لوب. نيجي للاكزيال ايمجز في السي تي as this is a mass lesion. المورفولوجي عندي في 3 signs very important to say that I'm dealing with a malignancy. ايه هما؟ الاوتلاين اللي speculated، الهيلو ساين. هيلو ساين is a sign of aggressiveness. يعني ايه هيلو ساين؟ ادي dense lesion surrounded by a ground glass opacity، يعني a less dense opacity, a gray lesion. اوكي. الحاجه الثالثه ان انا عندي التاجز، plural tags which join the lesion to the pleura and it suggests pleural infiltration. So these 3 signs are very important signs suggestive of morphologically ان انا بتعامل مع حاجه ماليه. طيب الحاجه الثانيه الليجن ده موجود فين؟ احنا شايفين Airway يبقى احنا upper lobe او apical of lobe. ادي مكان الفيشر اهو وادي مكان الفيشر، فده احنا كده ليجن قدام الفيشر ده apical of lower. الحاجه سوري posterior of upper. الحاجه الثانيه ادي الابر لوب برونكس داخل اهو مدي anterior segment و posterior segment، فالليجن ده related للposterior segmental bronchus. في focal lesion في الليفر. will I consider ده هرفع الستيجنج بقى اقول ان انا عندي metastasis؟ لا. الانسيدنتال ليجنز اللي موجوده في الليفر كتيره جدا، ف when I have a liver lesion تمام لازم يعني I will just describe it وبعدين هفحص الليفر نفسه بعد كده to assess لو هو ده metastatic lesion ولا otherwise. طيب another case هنا برضو we have a 65-year-old male smoker interstitial fibrosis وعندي a rounded lesion opacity اهي. This is a mass with partially well definition partial lobulation. لما نيجي بقى tissue characterization هلاقي ان ده city with contrast، في heterogeneous enhancement تمام، وفي هنا prominent extra pleural space دي sign that may suggest malignancy. Again ده male patient 60 smoker هفكر على طول ده وماس bronchogenic carcinoma is to be considered. هنا plain X-ray PA and lateral. We have a very large mass lesion. هفكر هنا في bronchogenic carcinoma؟ لا. المورفولوجي هنا عندي a very smooth outline. رغم ان الليجن very large we have a very smooth outline. طب هو البرونكوجينيك ما ينفعش تبقى smooth outline؟ يعني ممكن وهي لسه single pulmonary nodule وهي لسه صغيره تبقى smooth outline، لكن it can never reach such a size keeping very smooth very benign looking lesion. اول ما بنشوف ليجن بهذا الحجم this is a benign looking، مش بس benign looking it raises the possibility I'm dealing with a cyst. I'm dealing with a fluid containing cyst. Smooth large lesion with outlining like this. This is the case, actually it was a case of solitary hydatid cyst. حالة تانية بتأكد هذا الكلام برضو female patient at 7th decade. هنا بصوا حضراتكم very well defined smooth large mass lesion. لما نبص على tissue characterization it's totally fluid content, again the case of hydatid. دي كانت حالة كوفيد. اوكي، اللي لقيناه غير الليجنز الكلاسيك بريفرال ما كانوش كتير، لقينا this mass lesion with partial ill definition of the outline. لما نبص جواها هنلاقي there are dilated bronchi here. الماس ما يعملش dilated bronchi. الماس يا هينفلتريت وهيقفل البرونكاي يا هيفيزم، لكن dilatation is a sign of traction, sign of fibrosis. طيب طبعا البيشنت اللي كان عنده المنظر ده كان يعني جاله هلع من المنظر، he was afraid of bronchogenic carcinoma and so، بس هذا المنظر actually is a part. احنا الكوفيد 19 الفايندنجز بتاعتها بتبقى يا اما بسبب اتيبيكال المنظر اتيبيكال انفكشن فيرال انفكشن او بسبب الاورجنايزنج نيمونيا. فده منظر من المناظر الاورجنايزنج نيمونيا اللي هو مس. 2 weeks later it has disappeared completely. تمام؟ طيب هنغير بقى في المورفولوجي شويه. We have a male and 65 years old. عندنا ماس. جوه this mass we have a hole, a cavity. What's a cavity؟ مهم جدا نعرف مفهوم الكافيتي، برضو من الحاجات اللي بتعمل لخبطه. ايه الفرق بين الكافيتي وايه الفرق بين السيست؟ مفيش اي صله بين الكافيتي والسيست اصلا. بمنتهى البساطه الكافيتي I have to have a lesion and inside this lesion I'm going to have a hole. يبقى الاول لازم في ليجن. الليجن ده قد يكون ماس وحصل فيه هول، قد يكون نوديول وحصل فيه هول، قد يكون كونسوليديشن وحصل فيه هول، لكن في اصل ماس، في ليجن اصلي واتخرم هذا الليجن حصل فيه كافيتيشن. اوكي we have this bronchogenic carcinoma with a cavitation. المنظر ده له differential diagnosis which is very important اللي هو an abscess. I'm having a cavity, a mass with cavity. The most important differential diagnosis to this is having an abscess. How can I differentiate if this is just an abscess or I'm dealing with a cavitating bronchogenic carcinoma? 2 important findings are extremely important to assess. Number 1, if I have an eccentric lumen, number 1, and number 2, a non-uniform wall thickness, I'm dealing with a bronchogenic carcinoma. While if I have a central lumen and a uniform wall, this is an abscess. طيب let us verify this. طبعا ده حالة كانت actually bronchogenic carcinoma دي. In this case عندنا اللونج ويندو، ادي الليجن اهو ماس وفي lucency which is actually eccentric. طب هل انا كده بتعامل مع برونكوجينيك كارسينوما؟ لازم اعمل ايه؟ اعمل ميدياستاينال ويندو. لما نيجي نعمل ميدياستاينال ويندو هلاقي لا، ما هي اليومن it had fluid and air locules. So the lumen actually is central, not eccentric. The only thing that was apparent in this window was the locule, so it gave me a appearance of a misunderstanding that we are dealing with eccentric. However, it is totally central with a totally uniform wall. This is an abscess. يبقى strengthen تاني and it's very important to see the mediastinal window for tissue characterization. There is also another abscess in the spleen here. Another case of an abscess, central lumen with fluid and air fluid level and a uniform wall. Another case. Now here we have 3 different lateral and PA films of 3 different patients. All of them have ruptured hydatid. Here we have, in this first case, there is a fluid level, but this fluid level is wavy. The wavy fluid level is what we call the water lily sign, and it presents rupture in a leg. طب هل الwater lily sign is diagnostic only of hydatid disease? No, it's not. Any fluid level with debris on top or hemorrhage on top can have such an appearance. Okay, So water lily sign, it is seen in cases of rupture in a layer of hydatid. While in those two cases with hydatid, we have a crescent or meniscus sign, and this is happen when there is a rupture but with intact inner layer. In this case, female patient, 6 decade, we have a mass lesion in the mid-zone of the left lung. Am I dealing with a bronchogenic carcinoma? If you go to the CT, well, it is very suspicious in the lung window, and we have another lesion related to the mediastinum here. Doing again لازم نعمل الميدياستاينال window. عندنا هنا الدنسity is hypodense compared to the soft tissue of the chest. تمام. This is hypodensity. We're dealing with a fluid density. Again here a fluid density, and we found another lesion in the liver. We suspected hydatid, and actually the case was serologically proved hydatid disease. This is a case of hydatid disease with a single right lower lobe hydatid cyst. And a male, 60 years, heavy smoker with a mass lesion with lobulated outline. Are we dealing with a bronchogenic carcinoma? We should do what? To see tissue characterization. لازم أبص على الميدياستاينال window. Mediastinal window وراني heavily calcified lesion that can only be a calcified granuloma. تمام. الحالة دي young male patient. He was in a wedding and he got some gunshots, as you can see. He went to do an X-ray and an incidentalloma was present, a lesion that is incidentally discovered. He did a CT and the mass was seen in the lingula, in the lung window, while in the mediastinal window no lesion whatsoever was seen. طب راح فين الليجن؟ بمنتهى البساطة it's a fat density similar to this. Fat density are dealing with a lipoma of the lung, which is an extremely rare lesion. مهم جاء بعد سنة عمل فولو اب. الفولو اب بعد سنة وراني بقى فيه soft tissue component و popcorn calcification. This was actually a case of hamartoma in progress. He had a hamartoma. Right. And we have a very characteristic lesion, very interesting one. We have a peripheral lesion with a lobulated outline, with vessels supplying this lesion. The most important thing about this lesion is the vessels supplying it are very prominent. طب نعرف منين ان الvessel دي prominent وعندنا measurement؟ لا, we compare to the other side. This is the normal caliber of the vessel in this region. This is the importance of comparison of sides. This is a very prominent vessels going to it. So when we have a lesion, peripheral with lobulation or smooth outline, whether nodular mass, markedly prominent vessels supplying it, this is an AVM. If we have an AVM, okay, أنا خلاص كده شخصت AVM ممكن. تمام. خلاص أكتفي بهذا القدر؟ لا, مش هكتفي بهذا القدر. عند لازم يتعمل له CT pulmonary. في هنا حالة تانية برضو. This was an elderly female coming with hemoptysis, chest X-ray showing a lobulated large mass with prominent interlobar artery related to it, and another lesion. Again, AVM consider. CT was done, and the CT pulmonary angio is relatively old, about more than 15 years old. تمام. المنظر مورينا ال AVM والمالتيبل lesions والسبلاي من interlobar artery والدرينج في الانفيريور pulmonary vein. احنا بنعمل هنا CT pulmonary angio ليه؟ احنا شخصنا الحالة AVM، بس احنا ما بنشخص for the fun of it. احنا بنشخص عيان to treat. To treat we need to know the number of vessels supplying. الفيسلز دي جاية منين؟ عددها قد ايه؟ draining veins كام واحد ورايحين فين. Okay, but we must do a CT pulmonary angio in spite of the fact that we know it's an AVM. طيب. عندنا هنا another peripheral lesion. بس peripheral lesion ده has many characteristics that should be known by heart. Number one, this peripheral lesion, which may be a mass or a nodule. Here we have a mass. Subjacent to it, there is pleural thickening, and medial to it, joining it to the hilum, there are crowded markings. تمام؟ يبقى أنا عندي ثلاث حاجات. A triad of crowded markings. Okay, crowded markings mean volume loss, and a mass lesion, which is peripheral, subpleural, and a pleural overlying pleural thickening. This triad equal actually round achilles. Here we have another interesting finding. We have a well-defined lesion superimposed or seen in the side of the left hilum, and as you can see, an intercostal tube. Going to CT, this lesion is in the site of the major fissure. Seeing the tissue characterization, it is totally fluid containing. It's actually a fissural lesion, as you can see, and the tube is seen crossing here. This is a loculated fissural effusion, which may be named left pseudo-tumor. Another case, also a well-defined lesion seen in the site of the left hilum. Okay, this is a plain X-ray. In CT lung window, we see the lesion as oval, and another level is ribbon-shaped. Distal in the lesion, there is oligemia. Okay, this oligemia, is a vascular problem or is it air trapping? We see that this oligemia is surrounded by compression of adjacent structure and contralateral shift of the heart. If you look at the heart here, it's slightly shifted to the right. So there is a mass effect in this hyperlucency. This is air trapping. So we have a lesion with distal air trapping, and in the mediastinal window, we see hypodensity, fluid density. This appearance is typical for a bronchocele due to bronchial atresia. Spot diagnosis. Now coming here, we have a vague lesion in the PA film, vague opacity in the middle zone of the left side, while the same lesion in the lateral film is defined, well defined, okay, or more or less oblong in shape, and related, actually it's related to the major fissure, left major fissure. يبقى كان vague هنا بقى well defined, have a pleural relation, and there is an associated pleural lesion. This 3 points that we have just discussed change in the configuration from PA to lateral, one ill-defined, one well-defined, number 1. Number 2, having a pleural relation, which is a major fissure here. Number 3, ipsilateral pleural lesion is also visible. These 3 lesions suggest, 3 findings suggest that we are dealing with a pleural lesion. Okay, not the classic, of course, effusion and so on. This is a loculated effusion. هننقل بقى نقلة تانية. We'll shift to another thing. Now we've finished with masses. We're going to go to nodules. This is a case, we have a calcified lymph nodes, a thing that we all see all the time in the hilum, and associated with a calcified Gons focus here. Okay, this is right calcified primary pulmonary complex. It's one of the common findings that we may see. In CT, another patient with calcification in the hilum and a calcified nodule in the lung, again calcified primary complex. This patient had a scar in the right upper lobe, okay, with decreased volume of the upper lobe. As you see, the fissure is shifted. This scar is actually is rather suspicious, have a rather suspicious look. Okay, it was associated nodules spread in both lung fields and thickening of the fissure. In the mediastinal window, it is of soft tissue density. There is also, as you can see, calcifications here. It's healed tuberculosis. Patient had a history of healed tuberculosis. Okay, but still the scar is very suspicious. PET CT was done, and as you can see here, part of it has hypermetabolic activity, had tracer uptake. Okay. And this suggested a scar, a carcinoma, which was proved to be an adenocarcinoma. Okay. Here we have a patient coming with hemoptysis. Lung window showed a subsolid nodule, as you can see, partially solid, partially ground glass. Okay, partial of it is of soft tissue density in the mediastinal vein. PET CT was recommended for this patient, and actually it was done and referred to me, because they didn't find any uptake in the lesion. So the question I was asked, there is no uptake, is this, are we dealing with an inflammatory process or dealing with sarcoid or whatever, what is this lesion? Well, actually, if it was inflammatory, there would have been some uptake. No uptake means scarring. No, this is not the appearance of scarring, but there is a lesion, subsolid, which didn't take any tracer in the PET CT. This is very suggestive of adenocarcinoma in situ, and the case was proved to be an adenocarcinoma in situ. Again, an incidentaloma lesion incidentally discovered. This patient had a CT for interstitial disease, and this subpleural nodule was incidentally found. Okay, we need to examine this nodule. How would we do this? We do this by thin thin sections of CT, very thin section of mediastinal window CT. Okay, what did we find? We find that it has fat component, it has calcification, and it has soft tissue component. So this lesion is actually a hamartoma, which is a common incidental. Again, this patient had high resolution CT, and we incidentally discovered this left basal nodule. CT, high resolution CT, is not supposed to assess masses and nodules. So we have changed the window and we started examining the lesion by a normal lung window. We found that the content of the lesion suggested fat. So we shifting to the mediastinal window. Okay, there is fat. Are we dealing with a hamartoma? So here we have a very suspicious lesion of single pulmonary nodule. Shifting to the lung window, we had and the mediastinal window, what we had is appearance suggestive of fat. Going through the mediastinal window, there was suggestion that there is a perforation or there is an opening in the diaphragm here, a defect. So reconstruction images showed that we actually have a defect in the diaphragm, and this was nothing but a small diaphragmatic hernia with fat, pocdalic hernia. Okay. Another case with a very suspicious right lower lobe nodule. Okay. Going to the tissue characterization, mediastinal window. The density of the nodule is lower than that of soft tissue, higher than that of fat, which suggested fluid density. Reconstruction imaging showed that actually it is not a nodule at all. It's a tubular lesion, and it was actually a bronchocele. The message to convey here is that we need to have tissue characterization, we need to see mediastinal window, we need to see multiplanar imaging if we do have this facility. Again, a case showing a nodule in the lower part of the left lung. Tissue characterization, mediastinal image show fluid density, multiplanar imaging show that we have actually, this is the site of the fissure and this is only fluid in the coronal image. Again, tissue characterization, multiplanar images. Now we'll shift from a single pulmonary nodule to multiple nodules. And when we say multiple, we mean more than one. Okay? More than one. Starting from 2. When we have multiple nodules that are well defined, as you can see here, the first possibility and most important possibility is metastasis, even if we don't have a history of primary. We have 3 different patients with metastases. This one has only 2, this has more than 1 with different sizes, and also this one has more than 1 with different sizes. This is metastasis. Now here we have again a case of metastasis, multiple nodules with also affection of the chest wall. Again, this is metastasis. Nodules are well circumscribed, well defined lesion. Another case of metastasis, okay, CT, with multiple well defined nodules, affection, also there are metastases in the mediastinum and in the chest wall. This was a case of urinary bladder carcinoma. Here we have 2 important things to say. Again, we have multiple nodules that are well demarcated, well defined. This means we are dealing most likely with metastasis. This is first item in the R differential diagnosis. But we have to discuss 2 things. First, the angiocentric sign. What's angiocentric? When we see a vessel ending in the nodule, this is an angiocentric sign, and it means that this nodule is blood-borne, okay, which could be metastatic or inflammatory infection, whatever. The second thing is, in this case with metastasis, we have pleural effusion. When we find pleural effusion in a case with known metastasis, pleural effusion is considered as pleural metastasis until proved otherwise, okay? So pleural effusion in a case with metastasis is considered pleural metastasis. Another case with metastasis, different morphology. We have here calcification in the lesions and calcification in metastatic lymph nodes of the mediastinum. Again, calcified metastasis. Now we're going to make some changes in the morphology. We have again multiple nodules, metastasis considered, but these nodules have something which is very interesting. In this configuration, it has an umbilicus. There is umbilication here. The first thing to consider such an appearance is hydatid cyst. However, metastasis still can present with such an appearance. Going to have another change in morphology. Instead of the well definition of the lesions, we have nodules which are rather irregular and some of them and ill-defined. This is a case of sarcoid. Okay, and in addition, we have this also perihilar opacities and hilar fullness. This is a case of sarcoid. So when we have now nodules that are not sharply demarcated, okay, we will consider the possibility of inflammatory or infection, okay, and we will not consider metastasis mostly. In this case, we have again irregular looking nodular opacities, which are bilateral. They are flame-like opacities. Some are subpleural, related to the fissures and related to the pleura. Prominent bronchocentric interstitium is present here. Some ground glass opacification is present. This appearance actually is typical of Kaposi sarcoma. This case was sent to me from one of my students working at one of the Central African countries where Kaposi sarcoma is actually endemic. Again, to strengthen the point, when we have well-defined nodules, we have to consider metastasis. Irregular nodules, we are dealing with something which is different, inflammatory infection. And in some areas we have, and some patients, we may be dealing with things like Kaposi sarcoma, which is actually a virus-related sarcoma most of the time. Now here, we have another thing. We have well-defined lesions, okay, but those lesions, some of them show cavitation, another change in morphology. When we have well-defined lesion, again, we have to consider the possibility of metastasis. Adding to it the cavitation of some lesion, we will have differential diagnosis, considering the possibility of inflammatory or infectious lesions, okay. If those nodules with cavitations are bilateral and are countable, we may also add a third differential diagnosis, which is a vasculitis, okay. Here we have nodules which are well defined and some of them showing cavitation. So we have the three possibilities. Actually, in this case, it was a female 62-year-old with brain deposit. They were looking for primary, chest CT was done and it didn't find a primary, but found metastasis with cavitation, as you see. Now here we have numerous, not counted, we have numerous bilateral nodules and some of them showing cavitation, okay, and showing angiocentric sign. Here we have the possibility of metastasis versus an inflammatory or infectious process. This is okay. Actually, we had the history, female 9 years old with neglected inflamed fracture, and these are pyemic abscesses. In this case, this was a female patient with male patient, with chronic renal failure, and we find the bilateral multiple nodular opacities, as you can see, with cavitation. Some of them are rather bizarre in appearance. We considered infection, or typical infection, and it was a proved case of Aspergillus fumigatus infection. Now here we have another case, a patient with operation and nodules and cavitation and abscesses, a case of infective endocarditis with pyemic abscesses and even affection of the liver. Here we have a bilateral affection with countable lesions. Some of them are smooth, but some of them are not, okay, and there are cavitation. Having irregular nodules, as we can see here, will most likely we are not dealing with metastasis, we're dealing with an inflammatory process, infectious process, versus vasculitis. This case in 27-year-old patient, it was proved to be a case of Wegener granulomatosis. Nodules, cavitation, irregular nodules, bilateral, countable. A very strange appearance here, and a rule in medicine in general, not only in radiology: don't panic. Don't panic. Just look properly and try to assess the problem you're dealing with. Those are actually, we have nodules here, and those nodules are cavitating. Some of them are bizarre and complex appearance. They are bilateral and they are countable. We may be dealing with atypical infection versus a case of vasculitis. Again, this was a case of Wegener granulomatosis. Here we have cavity lesions, multiple cavity lesions, scarring and nodules, and we have a parenchymal bands on the left basal area here. Parenchymal band is a linear opacity reaching to the pleura. It represents scarring, so we have mostly scarring and nodules, okay, and cavitation. Bilateral and countable. Vasculitis considered versus a post-inflammatory process. Upper abdominal images show this lesion related to the left kidney, subcapsular lesion in the left kidney. This was actually a case of Wegener granulomatosis where they tried to take a blind biopsy from the left kidney. Now in this case, which is a very interesting one actually, you might also get puzzled with the findings. Some may say we have bronchitis. Actually, the bronchi are totally normal and we have numerous lesions. This cannot be bronchitis. If you look at the periphery, we will see nodular lesions, and they're very clear periphery on the right side. And then we go and we will find that some of the nodules are cavitating. So we have multiple nodules, okay, with some of them or most of them are cavitating. If we look at the coronary reconstruction images, we'll see that these lesions are upper lobar in distribution. So we have bilateral, fairly symmetrical disease. Okay, and we will come to this later, having signs of interstitial disease or chronic diffuse infiltrative. The lesion here is nodules with cavitation. This case was a case of pulmonary Langerhans cell histiocytosis. Pulmonary Langerhans cell histiocytosis starts by being nodules, okay, centrilobular in position, and then they cavitate and they change into cysts. We usually see them in the phase of being cysts, upper lobar cysts, rather than this early phase of nodules and cavitation. Now we have here another case with nodules, multiple nodules, but they have a very interesting finding that they have a tendency to be subpleural. And mind you, subpleural is not peripheral. Subpleural means sticking to the pleura. This is very important. Now, if you look at those lesions, we'll find variable appearance, variable shape. They are multiple, have variable shape. Some of them are cavitating, but most of them are actually sticking to the pleura. This is a classic feature of rheumatoid nodules. Rheumatoid nodules classically can be any number, any size, any shape. They may cavitate. They are not known to calcify. Okay, these are rheumatoid nodules. Here we have another case of rheumatoid nodules. We have only two, larger than the previous one. One of them is partially smooth, other is irregular, and tendency to cavitation is noted. Shift to another lesion now. We have the miliary pattern. What's the difference between miliary pattern, miliary shadowing, micronodules? What are the difference? The unit of the miliary is micronodules. When we have uncountable numerous micronodules, this is miliary, okay? When we describe them in a plain X-ray, we may say miliary shadow or miliary pattern. We don't use the word shadow in CT because we don't have shadows in CT. You see the actual lesion. So in CT, this is miliary pattern. In plain X-ray, it's miliary shadowing or miliary pattern. This is miliary, which means I'm having numerous micronodules. Okay, this was a case actually of 17-year-old female patient with ovarian carcinoma, and these were metastatic. Now coming to this case, we have again miliary pattern, and as you can see in the axial images, we have effusion. Now let us shift to the scanogram. You can see the miliary pattern on both sides. How do we see effusion here? Scanogram means a patient is supine. So how does effusion appear in a supine patient? Number one, if you compare both lungs, you will find veiling in the right lung because of the effusion. This is number one. There will be veiling, diffuse veiling, and then there will be here pleural capping. This is the apex here. There is a pleural capping here, okay? Because the water gathers in the most dependent part, which is the apex, and then it extends onto the lateral aspect and then basally. So we will have opacification apically, laterally, and basally, okay, in addition to the veiling. This is how effusion is seen in a supine film. This was actually a case of miliary tuberculosis. In addition to the miliary shadows, we have the effusion and we have a consolidation here. Now, mind you, this effusion in the supine position, the anterior margin of the effusion, or the margin of the effusion, is parallel to the rib. And this means I'm dealing with a free effusion. It is exactly parallel to the concavity of the ribs where it is present. Okay, this is effusion. Multimorphic lesions where more than one lesion is present suggest tuberculosis. Now, what do we have here? We have again multiple nodules, but they are different in appearance than the miliary. They are bigger, they are denser, and they are more irregular. These nodular appearances are what we call acinar opacities. Here they are associated with cavitary lesion in the apex, with cavitation with mycetoma, cavities and cavities with mycetoma. And this is actually a case of tuberculosis with transbronchial spread and what we call pneumonia, tuberculous bronchopneumonia. These are acinar opacities, acinar nodules. Now finished with the well-defined rounded opacities, now let us shift to the well-defined lucents. Now we're discussing a black lesion, okay? A black lesion without a wall, a black hole without a wall is emphysema, while a black hole with a wall is a cystic. This is the easiest way to know a cyst, okay? Now let's see here. These are the upper lobes, as you know, and there are numerous black holes within. These black holes are emphysema. The emphysema that affects the upper lobe predominantly, as you can see it here, is centrilobular emphysema. Here we have black holes that are peripheral. They are indenting the adjacent lung. In spite of being small, they exert a mass effect on the adjacent lung, and they don't have a wall. These are the bulla or blebs, which represent paraseptal emphysema. Paraseptal emphysema are bulla and blebs, and actually a bulla is more than 1 centimeter, a bleb is less than 1 centimeter, and this is how they look like. Now here we have a large bulla. If you look at it, it is as if it's a black mass. It is as if it's a rounded black mass. More than one bulla with a bulli here separating, and they are exerting a marked mass effect on the adjacent lung, no wall, paraseptal emphysema in the form of bulli. Here we have a hole with a wall. Hole with a wall is a cyst. Now, coming to cysts, we have single cyst with a certain differential diagnosis, multiple cyst with a certain differential diagnosis, bilateral cyst with a certain distribution, and this will have another differential diagnosis. We have a single cyst here. What is the possibility? Well, actually, there are congenital causes, traumatic causes, inflammatory causes. There are so many causes. Unless you have a definite history or previous film, this is just an air-containing cyst. You measure it, and you say, where is this? Could be the cyst, lungs air-containing cyst be congenital? Yes. A bronchogenic cyst in 15% of cases can be a solitary lung cyst, and it will be air-containing, not like the mediastinum where it is fluid-containing. Okay? So it could be congenital. A bronchogenic cyst could be congenital. Cyst here, this is a lung cyst. Here, on the other hand, we have also a cyst, but it is surrounded by signs of trauma. As you can see, the ribs multiple fracture. This patient had trauma weeks before. Actually, he had a laceration, and this was a post-laceration cyst. Okay, so weeks after trauma, with signs of trauma, as you can see in the rib fractures on the right side. So, cyst may be post-laceration. Here, their cyst was healing infarction. When a patient have an infarction, it might heal by total resolution or leaving a nodule, a fibrotic nodule, or a fibrotic parenchymal band, or leaving a cyst, as you can see here. This is a cyst which is post-infarction. Now here we have an interesting fact. We have multiple cysts. Why are these cysts? Again, to remind you, holes with walls. Okay? What is the etiology? What is the cause here? If you look at the lung surrounding those cysts, you'll find oligemia. There is no proper vessel in these lungs. Cysts surrounded by oligemia suggests this is actually equals cystic bronchitis. Why should cystic bronchiectasis be surrounded by such oligemia? Because this part of the lung is not functioning properly, so it is not supplied properly by blood supply. Now, what do we have here? We have cysts, what looks like multiple cysts with intervening bands and opacification. This lesion here in the upper lobe is associated with shift of the mediastinum towards it. So we have multiple cysts with ipsilateral shift. Ipsilateral shift of the mediastinum means this lesion is associated with volume loss. So we have a lung with volume loss. That means we have a collapse. Okay, the collapse that looks like this is what we call cicatricial collapse. Cicatricial means fibrotic collapse caused by fibrosis. So this is cicatricial collapse. Now we have a similar appearance here, multiple what looks like cystic, a bizarre shaped cystic lesion together with opacities in between. But here we have shift of the mediastinum, of the fissure. There is mass effect here. The fissure is displaced by the lesion. This lesion actually could be lobar, and in this case, it could be segmental, it could be subsegmental, it could affect the whole lung. This is a congenital pulmonary airway malformation. It looks like this. It has another name, congenital cystic, which is the old name, congenital cystic adenomatoid malformation. And it is one of the congenital lesions that we see in adults. Now again, we have here bilateral cysts. Okay, we have bilateral cysts that are seen in the upper lobe and in lower lobe, so it is dispersed in both lungs. And we have bilateral pneumothorax here. Okay, this was a young female patient with LAM, lymphangioliomyomatosis, bilateral diffuse cysts. Here we have clusters of cysts that are predominantly basal, and elsewhere they are subpleural in location. Clusters of cysts, as we see here, with filling of the pleural recess. These are honeycombing, and this is classic for usual interstitial pneumonia. Another cyst distribution, bilateral again, fairly symmetrical, upper lobes predominant distribution with bizarre looking cysts. Okay, this is a classic, as in a young male patient, this is a classic appearance for pulmonary Langerhans cell histiocytosis. Now, mind you, pulmonary Langerhans cell histiocytosis is totally different from the histiocytosis of children. Pulmonary Langerhans cell histiocytosis is an interstitial disease of smokers, of adult smokers. Now, okay, what do we have here? We have an appearance that is different from all the cysts that we have described. There are bilateral cysts, they are mostly medial, and they are basal, and actually we have vessels entering those cysts related to the wall of those cysts. This is a rare entity, a very rare entity actually. It's what we call Birt-Hogg-Dubé syndrome, which is an autosomal dominant syndrome. Why I'm presenting it here to tell you, okay, there are common lesions that you will meet a lot, but sometimes you will meet something out of the way. Okay, you start looking it up, and this one of the things that are out of the way, which is the Birt-Hogg-Dubé syndrome. To shift now, we have finished with well-defined lesion. We will shift to opacities that are patchy, that are ill-defined. Touch, we were dealing with fibrosis, collapse, and consolidation. Now, regarding fibrosis, I like to simulate the appearance of fibrosis that you see to a small story where we have a white cloth where a dog has turned it into pieces. Okay, now imagine the white cloth torn into pieces by the dog. Anything that can you imagine that happened to this white cloth, you may see in the pattern of fibrosis. Now here we have again fibrosis, the white cloth torn into pieces, but it is present apical. This site of fibrosis will suggest in our country and most of our neighboring countries that we are dealing with healed tuberculosis, with apical scarring due to old healed granuloma. Now here we have again bilateral upper lobar, apical and posterior scarring and calcification. Again, we will consider this is the case of tuberculosis, healed calcification, healed fibrosis and calcification in upper lobar, bilateral upper lobar fibrosis. Okay, we have seen miliary TB, we have seen bronchopneumonia of TB, we have seen pulmonary Gons focus, we have seen now fibrosis, okay, and effusion. Now, in this case, what do we see? Realignment of the vessels. As you can see here, the vessels are not supposed to be parallel to each other. The realignment of the vessel is a sign of post-irradiation fibrosis. Now, if you see it bilateral, as in this case, they suggest either a bilateral lesion or a mediacentral mediastinal lesion. Higher up than this, we will consider a thyroid. Here, actually, it was post-irradiation fibrosis due to malignant thymoma. If you find this lesion unilateral, it may suggest a breast cancer, maybe, or an irradiation for a bronchogenic carcinoma. Bilaterality suggests means I'm dealing with a mediastinal lesion. This is extremely important because, as you all know, irradiation changes are restricted to the site of irradiation. Okay. Now here we have another pattern of fibrosis, which we call the parenchymal bands, where we have a linear opacity reaching to the pleura, having an angle with the pleura. Bilaterality of the lesion parenchymal band in this 36-year-old male patient may suggest an etiology of vascular insults, previous infarction due to DVT or whatever, because of the appearance here. Now, this osteophyte-induced pulmonary fibrosis we have met a lot lately, and it is many people get mixed up in cases of diagnosing COVID. We see here this ground glass opacification or reticulation related actually to the osteophyte. So it's an osteophyte-induced pulmonary fibrosis. It is usually seen on the right side, but sometimes we see it bilaterally. We don't mix it up with COVID-19 fibrosis. Now coming again to this appearance of cicatrization in the upper lobe with shift of the mediastinum, and this is cicatricial collapse, okay, of the upper lobe on the left side. Same appearance in this triangular lesion. Now, when Apache opacity, whether fibrosis, whether we are dealing with consolidation or collapse, reaches a fissure, it becomes well demarcated by a linear or a curvilinear appearance. So we have demarcation here by lines, meaning that we are dealing here with fissures. Okay, so this is collapse. Collapse of what? What part of the lung has collapsed? Where we have a triangular opacity between two fissures. This triangular opacity is related to the heart. What part of the heart, what part of the lung is related to the medial, to the right aspect of the heart? This is the middle lobe. So this is a middle lobe lesion with demarcation, meaning that I've reached the fissure, meaning that the whole lobe is affected. Is this a proper site of the fissure? No, it is not, because this fissure has moved toward the lesion. It has the lesion has regressed in size, and it is demarcated by this minor and major fissures. This is a total cicatricial collapse of the middle lobe in a female 18 years old. Now, again, the appearance of cicatricial collapse. Where is it? Beside the heart, meaning this is a middle lobe lesion, as you can see in the sagittal image. Beside the vertebra, meaning that the lower lobe is also affected, okay, as you can see also in the coronal image. So we have cicatrization, cicatricial collapse of the middle and the lower lobe. Is this the total lobe affected? Yes, it is the total lobe affected. Why do I say so? It's part of the lesion small, because it is demarcated by a line. Demarcation is a fissure, meaning that the lesion has reached the fissure, means all the lobe is affected. So this is cicatricial collapse of middle and lower lobes on the right side. Now we have similar appearance on both sides with sharp demarcation. Sharp demarcation is a fissure, means I'm dealing with the whole lobe. Okay, so we have both upper lobes are collapsed with cicatricial collapse. Doing sagittal image to confirm, as you can see, the one with the heart is the left lung, the one without the heart is the right lung. You can see the demarcation in the upper lobe, okay, cicatricial collapse. In the right lung, it is demarcated anteriorly and posteriorly because we have minor and major fissure, while in the left lung, it is demarcated only posteriorly because we don't have a fissure between the left upper lobe and the lingua. Okay, so upper lobe cicatricial collapse. We'll shift to another type of collapse actually. You can see here in the axial images, massive effusion compressing the lung. The lung is still aerated, and we have contralateral mediastinal shift. So this type of collapse is called passive collapse or relaxation collapse. Why do I call it as such? اللنج هنا مفعول به. The main, it's a victim. The lung here is a victim actually. It has done nothing. It's just being compressed by the massive effusion. Thus, it is collapsed passively. It has just relaxed to its normal side. And as you can see, there is contralateral mediastinal shift because the main hero here is the effusion. So the effusion has caused shift of the mediastinum, and it has caused the collapse of the victimized lung. Now, the next type of collapse, as you can see here, there is a disfigured, attenuated bronchus intermedius, and at a lower level, you don't see it at all. There is fullness in case of this female patient, as you will see, she has left mastectomy, and she came for follow-up to see if there is anything wrong with her, and we find this fullness in the area of the bronchus intermedius in the posterior mediastinum. Okay, and are we only deal with a mediastinal problem here, or there is another associated problem? If you go through with it, you will find that this lesion in the posterior mediastinum is extending to join another lesion in the lung, and they're both amalgamated together actually, and they have a well-defined curvilinear margin. Having a well-defined curvilinear margin and then joining the lower lobe, meaning we have a lower lobe, total lower lobe collapse. No aeration whatsoever. This collapse is due to obstruction, so it's an obstructive collapse, and result of obstruction, there is resorption of the air inside the lobe, so what we call also resorptive collapse. So this is a collapse of the lower lobe due to the lymph nodes in the metastatic lymph nodes in the mediastinum. And there are also metastases elsewhere in the lung. Obstructive or resorptive collapse. So now we have seen cicatricial collapse, okay, due to fibrosis, and has a very significant, a very special pattern. And we have seen the relaxation collapse, where there is massive pneumothorax, massive effusion, whatever, something causing compression and relaxation of the lung. And we diagnose it by that the effusion is the hero, because we see shift of the mediastinum. Then the obstructive collapse or the resorptive collapse. Finally, we have the final type of collapse. It's not very common in adults. Actually, it is more common in children. And this is what we call the adhesive atelectasis. It is only seen in case of post-irradiation pneumonitis. This is a case of bronchogenic carcinoma with irradiation. And it is, as you can see here, it is restricted to the area of irradiation. This is number one. It seen peripheral in location in the lesion as in the lobe. This is number two. Actually, it looks like consolidation. However, actually, pathological-wise, is this adhesive atelectasis. There are the four types of collapse: cicatricial, resorption, relaxation, and adhesive type. Now we come to an important finding, important item, which how does Lobar collapse look like? This is an important item, and it's actually sort of spotting. Now, this is an opacity in the upper zone, terminated by a sharp demarcation. Sharp demarcation of an opacity is a fissure. Okay, linear sharp demarcation is a fissure. Is this a position of the fissure? No, the fissure has shifted toward the lesion. So this means this lesion has volume loss. What is the site? This is definitely the upper lobe. There is no possibility of being anything else. This is upper lobe, the shift of the fissure towards it, retraction of the fissure. This is right upper lobar collapse. Then, again, an opacity with lateral here, we have shift of the fissure, but we have medially a convexity here. And this is what we call the reverse S sign of Golden, where the collapse is due to a central mass, which is very important. So you can see here two patterns that we have shown: a collapse with total retraction of the fissure, and a collapse with medial bulge, which is the S sign of Golden, suggesting a central mass lesion causing the collapse of the lobe. Now here another interesting finding. We have a veiling or an opacification of upper and mid zone of the left hemithorax or left lung. Now, do we have a central mediastinum or we have a mediastinal shift? Most of you will say, okay, we have more or less a central mediastinum. No, we don't have a central mediastinum. If you look here, we should understand very clearly that the position of the heart. It's very important. Now, normally, if in a PA film, if we have a midline line here, we will have 1/3 of the heart on the left of this line and 2/3 to the right. We don't have this here. We have the whole heart shifted to the left. This is number one. Number two, normally we should have a part of the heart on the right side of the vertebrae. Again, we don't have this. So this heart has been shifted to the left, meaning that this opacity has caused volume loss. It has moved the mediastinum and hearts towards it. Now, how does it look like in the lateral film? This is how it looks like in the lateral film. Now we have an opacity with sharp demarcation posterior. What is this demarcation? Again, a linear demarcation is a fissure. What is this fissure? This fissure will be the major fissure. This is not the normal position of a fissure. It has moved anteriorly toward the opacity. This is how the left upper lobe collapse will look like. This is a spotting of left upper lobar collapse that you should know, that you won't miss it if you meet it anyway. Now, again, you know now that this heart has been shifted to the left side. What caused this shift? Now, if we look here in a penetrated film, we find a retrocardiac triangular opacity. This is a left lower lobe collapse. Now we have seen the patterns of collapse of different lobes, and we here have another lobe. We have an opacity right basal, which obscures the right cardiac border. Right cardiac border is related to what? To the middle lobe. So obscuring right cardiac border will mean we have a middle lobe lesion. This middle lobe lesion in the lateral film, as you see here, has a rather concave margin. So what we're dealing with here is a right middle lobe collapse. To emphasize this finding, we will need to look at these cases. Now look here with me. Bear with me. This is a vague opacification in the PA film. The right cardiac border is clearly seen, okay? And in the lateral film, we have a lentiform biconvex opacity overlapping the heart, okay? And this biconvexity will be equal an insisted effusion of the inferior aspect of the right oblique fissure. So we have the previous lesion, we have a concavity, which means we were dealing and obscuring of the heart, meaning a middle lobe lesion which is collapsed. Here we have no obscuring of the heart border and biconvexity in the lateral, meaning we have an loculated effusion. In this case, we have now obscuring the cardiac border. We have the definition of the linear definition of the opacity, meaning this is the fissure, minor fissure here, okay, and this basal opacity obscure the heart and is delineated superiorly by the minor fissure. In the lateral film, we have a triangular opacity with straight lines. This one, the higher one, the upper one represent the minor fissure, and the lower one represent the oblique fissure. They are not retracted, they are horizontal, and they are smooth, and they are straight. Okay, so this triangular opacity represents right middle lobe consolidation, and we will come to know that lobar consolidation is a pneumonia. Now coming to consolidation, what's consolidation? Consolidation is when we remove the air from alveoli and we replace it by something else. So there shouldn't be any significant volume loss. Actually, no volume loss is expected. We may replace it by an infective cell, we may replace it by blood, by fluid, by eosinophilia, by malignancy. This is consolidation. Consolidation can be patchy, diffuse, lobar, unilateral, bilateral, central, peripheral, etc. Now, these are the appearances. All these appearances may be seen in cases of consolidation. Acinar opacities, patchy opacities, here air with air bronchogram, patchy opacities without air bronchogram. And by the way, what's air bronchogram? Air bronchogram is when we see the blackness inside the bronchi surrounded by opacification. This opacity surrounding the air bronchogram means that I'm dealing with a lung opacity. This lung opacity could be consolidation, could be collapse. Some malignancies may have this, simulating this appearance in cases of adenocarcinomas and lymphomas, etc. Sometimes. Anyway, the appearance, we may have a lobar distribution of consolidation. We may have diffuse bilateral distribution of consolidation. Now, to approach consolidation, we have to localize it, okay, and then we start to know what's the type, to have differential diagnosis. Now let us start by Lobar assessment of consolidation, Lobar appearance of consolidation. This is an upper lobe opacity, but now we have the minor fissure here appearing as a straight line. We have linear, lower linear well definition of the lesion. This means that there is no shift of the fissure, meaning that actually no volume loss. This is a consolidation of the upper lobe. Again, a lobar consolidation is most likely pneumonia. This is a middle lobe consolidation, middle lobe pneumonia, and we have described it before. Now, in this case, we have a basal opacification. The heart is not obscured. The right cupula is obscured. So this means that this opacity obscuring the right cupula is in the lower lobe. Having, there is no shift of the heart, okay? Now, having the lateral film, we will see that this opacity is posterior, demarcated anteriorly by the fissure. So this is a right lower lobe consolidation, meaning we have a right lower lobe pneumonia. Okay, now this is a CT, and here we have solidification of the right lower lobe, meaning we have consolidation with cavitations, as you can see, and with air bronchogram. This is a pneumonia. In this case, we have a complicated case of pneumonia. We have partial consolidation of the left lower lobe, but it is associated here by a cavity with a mycetoma inside. In addition, we have a lentiform thin pleural-based lesion with air fluid level, as you can see here. This lentiform air fluid level is a loculated hydropneumothorax. An loculated hydropneumothorax related to such infection without a tube is a bronchopleural fistula, complicating this infection. Now, this is a very interesting finding here. We have, this is the heart, so this is the middle lobe, okay? Inside this middle lobe, we have consolidation with an element of volume loss, okay? And we have tubular structure that are branching and that are white. This appearance is pathognomonic of allergic bronchopulmonary aspergillosis, which is one of the appearances of aspergillus affection of the lung. It actually takes place when a patient has asthma or have cystic fibrosis. This is how it presents, with fever and cough and etc. And this classic mucoid impaction that is white, okay? Why is it white? Because it contains iron and contains magnesium and calcium, okay? And because of its thickness, mucoid impaction. This classic appearance of allergic bronchopulmonary aspergillosis. Now we finish with lobar distribution of consolidation. We shift to another type of consolidation pattern, which is patchy. What do I mean here by patchy? Where the lesions are peripheral, the lesions are central. We can see air bronchogram, and the lucences within are what we call air alveologram actually. So this patchy diffuse appearance that affects both lungs has a very wide differential diagnosis. Here we must be guided by history. The commonest cause actually is a bronchopneumonia, but hemorrhage may have such an appearance, atypical patterns of edema, atypical pattern of eosinophilia. Some tumors may be presenting with this same pattern. It has a very wide differential diagnosis, okay? So the commonest is a bronchopneumonia. This was a case of 33-year-old male patient with bronchopneumonia, patchy and bilateral. Now, here another case. This was an elderly patient that was diagnosed for months as bronchopneumonia, and then finally they decided to take a biopsy, which proved at that time it was diagnosed as bronchoalveolar carcinoma. Of course, you all know that this terminology is no more in use, and this is one pattern of adenocarcinoma in the lung. Okay, and this patient is 60 years old female with patchy opacity seen, as you can see, and this is a very common history, by the way, this follow-up of pneumonia for months. Now what we have here is bilateral diffuse consolidation. This appearance has a relative limited differential diagnosis, and the patient is usually coming from an ICU with acute respiratory distress syndrome or acute interstitial pneumonia, and in both of them we have a severe injury of the alveoli. Now we have an interesting pattern here. Now we shift from the diffuse to the central. As you can see here, there are bilateral central consolidation. You can see the peripheral sparing of the lesion. This was a young patient with systemic lupus with heart failure and renal failure actually, and this pattern associated with effusion, visceral effusion, was due to alveolar edema in the lung. The totally opposite pattern of bilateral peripheral consolidation. This pattern is very common in eosinophilic diseases. Okay, the peripheral appearance of consolidation, bilaterality, and this was a case of chronic eosinophilic pneumonia. Another case that also presents by bilateral consolidation is the book or bronchiolitis obliterans organizing pneumonia. Organizing pneumonia, as you can see, sometimes is associated with the reversed halo sign, which is very pathognomonic for organizing pneumonia. This pattern of bilaterality we see a lot today in COVID-19 because, as I told you before, COVID-19 may present by pattern of atypical infection or pattern of atypical of organizing pneumonia. So this pattern is due to organizing pneumonia. These all are cases of COVID-19. They could be bilateral, and we see a lot of unilateral cases, actually, mild unilateral cases, as in this case. Now, here we have a unilateral peripheral consolidation. We are still discussing consolidation. We are now discussing peripheral consolidation, and we have shifted from the bilateral to the unilateral. This is a unilateral peripheral consolidation with cavitation, air bronchogram, and a pneumothorax here. This was taken, this CT was done 4 to 5 days post-trauma, and this how laceration will look like. Laceration will appear 4 to 5 days after trauma in the site of trauma, okay, and it will appear as a peripheral consolidation that shows cavitation within, and by time, as we have seen before, it will heal, leaving a cyst that will decrease in size by time. So a laceration is one of the appearances of unilateral peripheral consolidation. This typical appearance of a unilateral peripheral consolidation, which is a subsegmental affection, as you can see here, is due to an infarction. Another case of infarction, we have effusion. This is a sagittal image, and we have this infarction with a vessel, non-enhanced vessel supplying it. Again, a peripheral consolidation can be wedge-shaped peripheral consolidation is an infarction. Another peripheral lesion, here we have pleural thickening with calcification and a tiny nodule with crowded markings going to it. We have seen this triad before: pleural thickening, peripheral lesion, and crowded marking joining the lesion to the hilum. This is the typical appearance of round atelectasis. Now we have the opaque hemithorax, lucent hemithorax. Okay, one either black or white. Okay, what are the possibilities that we have? We have 4 possibilities: an opaque hemithorax with increased volume, an opaque hemithorax with decreased volume, a lucent hemithorax with increased volume, or a lucent hemithorax with decreased volume. Okay, the 5th possibility is that we have a hemithorax problem with no volume change, and this is have a very limited differential diagnosis. Now, to start with, we have total opacification of left hemithorax with contralateral mediastinal shift, a typical appearance of what? Of a massive effusion. A very interesting finding here, if you look here at this lateral film, we find that we can see the right cupula all through, and we don't see the left cupula at all, because actually this opacity is left-sided, so it has obscured the left cupula. So this number 1 opaque with increased volume is effusion, massive effusion. Now, CT findings here, we have the massive effusion, we have the relaxation collapse of the lung, and we have contralateral shift. Now, here we have near total opacification of the right hemithorax, central mediastinum, air bronchogram, and cavitation. This is right lung consolidation. The air bronchogram is present, and there is no effusion. Now we have here an opaque hemithorax with ipsilateral mediastinal shift. Opaque hemithorax with ipsilateral mediastinal shift equal volume loss. What are the causes of volume loss? Either of two things. Either we have a collapsed lung or we have no lung at all. Now let us start. Collapsed lung means we see the lung, but it will be small, or we see in CT no lung. If we look here in this opaque hemithorax with ipsilateral shift, these axial images show the mediastinum filling the hemithorax. There is no lung. What are the possibilities of no lung? Well, either there was a lung and it was removed, or there is a congenitally absent lung. Can we differentiate? Yes, we can. How can we do this? By looking at the bronchial tree. If we see a well-formed bronchial tree, as we can see here, this means that there was a lung here. So here, as actually we see a well-formed left main bronchus, and we see even pleural calcification. So there was a lung. So this is a case of pneumonectomy. There is another important thing here. If you look at the right lung, you will see a large black lung. Large black lung with retrosternal herniation. This is compensatory hyperinflation. Why are we so sure of the diagnosis and say compensatory hyperinflation? Because we have a major problem on the other side. Okay, now let us see this case. Again, total opacification of left hemithorax with total ipsilateral mediastinal shift, mean volume loss. Looking at the CT, we don't see a lung. So, and we look at the bronchi. Though we have no bronchus, no, we have just a vestige of a bronchus. We have an ended, blind-ended residue of a bronchus on the left side. This actually what we call aplasia of the lung. If we don't see a bronchus at all, this will be agenesis of lung. If we see a vestige of the bronchus, this is aplasia of the lung. So this is a case of aplasia of the left lung. Now, what we have here is again an opaque hemithorax, okay? And there is no considerable shift of the heart, but there is slight ipsilateral shift of the trachea. When we go through the axial images, we find that we see the lung. So there is a lung. This lung is small in size, as you see in axial images. There is collapse, there is no air bronchogram, and there is obstruction, as you see here in the second image, obstruction of the bronchus. Endobronchial lesion is totally obstructing. This is a resorptive collapse. Effusion is noted. Parietal pleural thickening is seen. And we have multiple lymph nodes with calcification. We have also calcification at the hilum of the lung. What was this? Adenocarcinoma, metastasis, okay, to the mediastinum, to the pleura, and endobronchial metastasis in the lung. What carcinoma send such lesion? Breast carcinoma is known to send endobronchial metastasis. Renal carcinoma is also known to send endobronchial metastasis. There are other lesions, but these are the commonest known. Now look here at this lung window. You will see this is a conventional CT study. Still you see the coarseness of the right lung due to lymphangitis carcinomatosis. This is how lymphangitis carcinomatosis will look like in a conventional CT study. And you see, of course, the obstruction of the left bronchus. Now this is a virtual bronchography, okay? The upper one on the right image is the VB image, which is 3D image simulating the bronchoscopy, and you see the total obstruction. The one on the right below is the MINIP image, and you see the bronchial tree. You see whatever is black here. So you see the bronchial tree with total obstruction of the left main bronchus, and the one on the left side here, you have the 3D image, okay, volume rendering. Now, pay attention to these two lesions. We have seen those two cases. In both of them, we don't have a mediastinal shift. On the right side here, we have air bronchogram, and this is consolidation. On the left side, however, we have an endobronchial lesion. We have no air bronchogram whatsoever, and we have collapse and effusion, and this is absorptive collapse and effusion, obstructive collapse and effusion. These are to be differentiated. Now here we have heterogeneous opacification of the left hemithorax with ipsilateral mediastinal shift. If we look at the axial images, we see also pleural thickening and cicatrization of the lung. Again, this is cicatricial collapse of the whole lung and fibrothorax. Also, we have compensatory hyperinflation of the right lung with retrosternal and retrocardiac herniation, a big black lung. Here we have an opaque hemithorax. In axial images, we have the nodular circumferential thickening of the pleura, classic for mesothelioma, giving again in the plain film an opaque hemithorax. Now shifting from opaque to black hyperlucent hemithoraces, we have this classic appearance of jet black right lung with right hemithorax, with a total collapse. This is pneumothorax. Now, when you find a pneumothorax, you have to look at the mediastinum. Here we have no mediastinal shift whatsoever in spite of the massive pneumothorax that we have. So this is a spontaneous pneumothorax, massive spontaneous pneumothorax. While in this case, we have again the jet black hemithorax with marked contralateral shift, with a lung disfigured and collapsed and adhered to the chest wall due to adhesions, and the marked shift of the cupula. So the shift of the mass effect here mean we are dealing with a tension pneumothorax. Tension pneumothorax is a very serious condition and it should not be missed. So whenever you see pneumothorax, you have to look for mediastinal shift. Again, a black lung and a white lung. Which one of them is a normal? Actually, if you see here, you will find on the right side normal vascularity, while there is attenuated vascularity on the left, and there is minimal retrosternal herniation. So we have a black lung with retrosternal herniation, meaning it is enlarged. A big black lung, hyperlucent. Now, is this compensatory? Is this compensatory? No. Why do we say no so surely? Because there is nothing wrong with the right lung. So we have actually two causes to have a big black lung. The first one is compensatory hyperinflation, and this we have a sure diagnosis when you find a massive lesion on the other side. When we don't find a massive lesion on the other side and we have a big black lung or a big black lobe, whatever, we are dealing with emphysema. We are dealing with obstructive emphysema. And in this case, we can see the peanuts. This was a female child that aspirated a foreign body, which are peanuts, and this is obstructive emphysema. This is a very serious diagnosis. In children, it could be due to foreign body. In adults, it could be the early sign of a bronchogenic carcinoma. A big black lung with no evidence of compensation. Now, let us go to small black lungs. Here we have a small hemithorax, as you can see. What are the possible causes? Number one, I should look for a collapsed lobe, which is the case here actually. This is what we've seen before, left lower lobe collapse. So the lung we are seeing is actually only a hyperinflated right lobe. So a small black lung, number one, look for lobar collapse. This is collapsed lower lobe. Number two here, another case, we have again hyperlucent lung that is much smaller than the other one with a hypovascularity in it. What will be the possibility? We have a disfigured heart here. We have a case with lobectomy. You don't diagnose lobectomy unless you have a history. Okay, you don't just go and say this patient has lobectomy in plain films. In CT, you might look for bronchus obstruction, you may look for a fissure that is missing, but here you will just say, if you don't have the history, you will just say we have a small lung which is hyperlucent for clinical correlation. Now what do we have here? We have a small lung on the right side. We have shift of the mediastinum and heart. We have abnormal configuration of the mediastinum and heart. In this is a child actually, you can see the epiphyses here. Okay, now, is this lung only small or is it hypovascular? Well, compare the vessels in the axial images on both sides. You will find that the lung is small and hypovascular, and actually there are some abnormal vessels posteriorly. Why? What has caused this small lung? There is no lobectomy, there is no lobe removal, there is no lobar collapse. What is the cause here of this actually congenital hypoplastic lung? It's a small black lung, born as such. We find here, this is the main pulmonary artery and this is the left, they are enlarged. There is no right pulmonary artery. The bronchial arteries are prominent. There are pulmonary circulation in the lung, but they are not coming from the pulmonary artery. They are coming from abnormal ways. Here, this appearance is called proximal interruption of the right pulmonary artery. So the proximal part only is missing. Proximal interruption of right pulmonary artery, it is one of the causes of a hypoplastic lung, okay? Another case here, we have again a small lung, shift of the mediastinum and heart, abnormal configuration, and as you can see here, there is a suspicious vascular structure behind the heart here, okay, scimitar looking actually. And this is a coronal image. This is a scimitar syndrome, is what we call a hypogenetic lung syndrome, which is considered as partial anomalous pulmonary venous trench. Again, a small lung hypoplastic. Now here we have a small lung also, hyperlucent lung, but if we look here, there is nothing wrong with the configuration of the mediastinum, the heart, and there is a normal pulmonary artery, but it is a rather small artery with some calcification noted. This appearance actually we see in Macleod syndrome or Sawyer-James syndrome. What is this? Well, it's not a congenital condition. It's a patient having very early in life, he has severe unilateral chest infection or bronchiolitis, okay, and then the lung become later on small with a small vessel supplying it because it's not functioning properly. Now what do we have here? Now we have a hyperlucent hemithorax, okay, but there is no shift of the mediastinum. But if you go to axial images, we find clearly hyperlucent hemithorax with sparse vessels which are attenuated, and we do have here some element of retrosternal herniation. Now we know that a big black lung means obstructive emphysema, but we need to understand why there is no shift of the mediastinum. Going to physics, actually, if there is no shift, there may mean that there is something else balancing this mass effect. If we go to the next images, we find that there is still, they have lung tissue here. So is a hyperlucent, this is not pneumothorax, we have lung here, tissue parenchyma and vessels, sparse but present, and we have this lung opacity. The lung opacity is demarcated by a line. A demarcation of a line means this is a fissure. The lung beside the heart is a middle lobe. The lung beside the spine is a lower lobe. They are both delimited by fissure, so we mean we have a middle lobe and lower lobe collapse. This means that all what we see here is an hyperinflated upper lobe. And this was a 21-year-old patient with lobar emphysema. This is congenital lobar emphysema. Actually, this was the preoperative film of the patient after the lobe was removed. He came to us later, but I have made a copy of this study. So this is congenital lobar emphysema. We have only one lobe markedly emphysematous, obstructive emphysema. It's a congenital cause. The presence of the other lobes, some sort of balance the lesion. Now we go to diffuse infiltrative lung disease, which was previously known as interstitial disease. Why is the change of the name, which started at the 90s, by the way? Diffuse infiltrative lung disease is because actually this disease is not essentially totally interstitial. How could I diagnose a bilateral? When will I suspect it as a radiologist? بشوف ايه كراديولوجيست عشان افكر ان انا بتعامل مع interstitial disease او bilateral diffuse infiltrative disease. اول حاجه, first of all, bilaterality. I have to have a bilateral disease that is fairly symmetrical, and it's some sort of have site of predilection. It likes to be somewhere. It's more upper lobar, it's more lower lobar, it's more subpleural, more central, whatever. It have a site of predilection. Okay, the lesions that we meet in such entity of disease, we might see dots, okay, and these dots are called micronodules. We might see strains, and these are either inter or intralobular interstitium. We might see patches, okay, ill-defined opacities. Patches are ill-defined opacities. These opacities, either I cannot see lung marking through them, they what we call consolidation, or I can see lung marking through them, and this is what we call ground glass. So ground glass is an opacity through which I can see lung mark. Or it's a hole with a wall, which are cysts. But cyst here should be bilateral, fairly symmetrical, and have a site of predilection. Now let's proceed. Let us introduce you to cysts, to nodules. Now this is a pattern of central lobular nodules. This is how central lobular nodule may look like, okay, as if we are dealing with stars at night at the sky. Another case with central lobular nodule. This is a patient, heavy smoker, hyperlucent lung. As you can see, this is an azygoslope fissure. Upper lobes show those faint, ill-defined ground glass centrilobular nodules, and this is classic for respiratory bronchiolitis interstitial lung disease. Respiratory bronchiolitis interstitial lung disease is one of the interstitial lung diseases that are smoking related. Okay, this again is a pattern of centrilobular faint ground glass ill-defined nodules, okay, in a heavy smoker. Another appearance of centrilobular nodules you see here. Numerous centrilobular nodules that will make us mistake them for the miliary pattern. How can we differentiate? I'll just tell you now. Miliary pattern, here we use the word random nodules, okay? In centrilobular nodules that are numerous like this, actually, you can see the fissure as a hyperlucency. You can discriminate the fissure, hardly discriminate the fissure as a hyperlucency. And this numerous centrilobular nodules that you will see filling the whole lung, actually with relative basal sparing, is specific for the appearance of one of the appearances of subacute hypersensitivity pneumonitis. Now, in this case, we have micronodules again that we call random appearance. If you look here, you look at the fissure, you can see the fissure, and the fissure is actually beaded. So in micronodules that affect the fissure, that are numerous and affect the fissure, this is a miliary, this is the random micronodules. This is a random distribution. If we see, on the other hand, that we do not discriminate the fissure, as in this case, or actually we see the fissure as a hyperlucency, okay, this is centrilobular nodule, and this is pathognomonic of subacute hypersensitivity pneumonitis. This is random, this is miliary, this is a male 26-year-old, and miliary pattern differential diagnosis is extremely wide, as we used to take in the third year of college. All that end with osis is miliary, sarcoidosis, tuberculosis, pneumoconiosis, etc. Now, the third pattern of micronodules is a perilymphatic distribution. That means these nodules follow the pattern of the lymphatics. So they are seen subpleural, as you can see here. They cause beading and thickening of the fissure. This fissure is thickened and beaded. They are seen centrilobular because we have lymphatic centrilobular. How can I differentiate this from centrilobular? Only by looking at the fissure. So we have perilymphatic nodule, we have centrilobular nodule, we have random nodule. These are the three patterns of micronodules. Okay, centrilobular nodules do not affect the fissure. Otherwise, the random and the perilymphatic, both of them will cause the fissural beading. In case of random, the appearance is, as you can see here, numerous uncountable nodules. While in case of the perilymphatic nodules, this is a case of sarcoid, by the way, you see the few centrilobular nodule and the beading of the fissure, which is classic. Now, going to the prominent or the strandy opacities of interstitial disease or the chronic diffuse infiltrative, we have prominent interlobular interstitium. Interlobular means they separate the secondary pulmonary lobule. This is how they look like. This is how interlobular interstitium prominent look like. You do not see it normally. Normally, as we've said before, we see nothing as such. When we start to see the pulmonary lobule, this means that the wall of the lobule is prominent. This is a prominent interlobular septum. When do we see such thing? We see it in cases of, number one here, we see it in case of lymphangitis carcinomatosa. Here, as you can see, we have interlobular septa prominence, and in the same time we have prominent, or we have also perilymphatic nodules. So in addition to the interlobular septa, we have beading of the fissure, we have centrilobular nodules, as you can see basally here, we have beading of the interlobular septa posterior if you look at the wall, and we have also prominent bronchocentric interstitium. This patchy ground glass opacity that you see is due to post-irradiation. This was a female patient with mastectomy and irradiation and chemotherapy. Here, another cause of prominent interlobular septi is interstitial edema. This was a case actually of cardiomyopathy, ischemic cardiomyopathy, and as you can see here, there is fissural effusion, There is prominent interlobular septic, not as prominent as the one we have seen before. There are some patchy opacities. There is pleural effusion and there is cardiomegaly. Okay, and if you look basally in the sagittal image, those linear structures that you see are prominent interlobular septi. So the prominent interlobular septi here are more basal and more posterior because of the physics of fluid. Fluid will be more basal and more posterior. Interlobular septi here are prominent because of water in the interlobular septa due to edema. Now here, if you see posterior on the right side, just posterior to the heart and the diaphragm, there are few prominent interlobular septi. There are also nodules. Okay, this is a case of sarcoid, and in sarcoid you see multiple lesions. Actually, you don't see single lesions. Okay, there are nodules, there are perihilar opacity, there are hilar prominence, there are prominent interlobular septi. Again, a multimorphic disease. The two classic multimorphic diseases, meaning a disease presenting with more than one appearance of lesion, is classical tuberculosis and sarcoidosis. Now, shifting from the prominent interlobar to the prominent intralobular. Now intralobular interstitial. What we see here, you can describe as having reticulation. You usually describe this as reticulation. This is prominent intralobular interstitium, and it is only seen in interstitial fibrosis, what we call actually in radiology and pathology interstitial pneumonia. There are several types of interstitial pneumonia according to some changes here. For example, in this case, you find relative sparing of the direct subpleural area. So this prominent intralobular interstitium with the relative sparing of the direct subpleural area will suggest non-specific interstitial pneumonia. In this case, we have again the bilateral, fairly symmetrical lesion with predilection basally and subpleural. We have subpleural predilection, predominant basal affection. Pleural recesses are classically affected. Okay, those linear structure inside are traction bronchiectasis and traction bronchiectasis. And in addition, we have this structure. What is this? This is a dilated esophagus. This is a dilated esophagus. Okay, so this is an interstitial fibrosis with dilated esophagus. This is a case of scleroderma. In this case also, as you can see here, there is a cyst seen on the left side in the coronal image and anteriorly in the sagittal image. These cysts, in addition to the interstitial pattern of this disease, will suggest that interstitial fibrosis here is a type where we call lymphocytic interstitial pneumonia. Why? This is a pattern of interstitial disease fibrosis, bilateral fairly symmetrical subpleural, ground glass opacification, reticulation, prominent intralobular interstitia. In addition, the patient is known to be a case of collagen disease, which is scleroderma. This case is then lymphocytic interstitial pneumonia. Now, ground glass, but with a specific pattern, which is again predominantly basal and subpleural, with evident decreased volume of the lower lobe. How do we know there is decreased volume? We look at the sagittal image, we look at the fissure. The fissure is retracted toward the lower lobe. Bilateral, fairly symmetrical, subpleural, predominantly basal, ground glass opacification with filling of the pleural recesses. This is a typical appearance of, again, early interstitial pneumonia. What do we have here? We have a bilateral disease with a mosaic pattern. What's mosaic pattern? Mosaic pattern is when we have intermingled ground glass and opacities. What does mean intermingled? Together. يعني كان حد مرة وصف هذا المنظر يقول لي اللنج مبقعة. Sorry في اللفظ بس هي فعلا a very typical appearance. We have both lesions intermingled together. مفيش حاجة فوق وحاجة تحت، حاجة بره وحاجة جوه، لا هو متداخلين مع بعض. الليجنز الأبيض والأسود متداخلين. But we have a dominating ground glass. So we have a bilateral diffuse mosaic pattern, dominating ground glass pattern with intervening areas of what? Lucences. Lucents دي representing ايه؟ هنبص على, if we look at some of them, we will find total lucency with no respectable vessel seen within, which means that we have perfusion problem in it. Other lucences will find normal lungs. So intervening lucences representing mosaic perfusion and representing normal lung. With actually, if you look basally, there is relative sparing of the disease. This appearance is pathognomonic of subacute hypersensitivity pneumonitis. So, subacute hypersensitivity pneumonitis may appear as bilateral, diffuse, centrilobular ground glass nodules. This is, if you see it early. Later on, what we see is actually bilateral mosaic pattern with predominating ground glass opacification, intervening areas of lucencies that represent areas of hypoperfusion or aperfusion, and areas of normal lung with relative basal sparing. Subacute hypersensitivity is a radiological diagnosis because clinically it simulates any other interstitial disease. The patient is coming with chronic dyspnea and dry cough. If we do a pulmonary function test, it will only show obstructive changes and maybe even show mixed changes. If we go on with a biopsy, if you biopsied in a wrong site, you have to diagnose such a lesion, you have to have a biopsy from the ground glass, a biopsy from normal area, biopsy from the area of perfusion. You have to pick up many biopsies so that you reach out that the addition of all these together will suggest for the pathologist if this can be done even, that we are dealing with subacute. But in high resolution CT, there is a pathognomonic appearance. This is the pathognomonic appearance of subacute hypersensitivity pneumonitis. What is subacute hypersensitivity pneumonitis? Well, it is considered as an interstitial disease. It may be considered also as an organic pneumoconiosis. Patient inhaling some infectious organism, inhaling certain organic dust and so on, patient raising birds, patients working with hay, etc. Farmers, all are subjected to such disease. Now coming again to the cysts. So we have finished with dots, macronodules, we have finished with strands, prominent inter and intralobular interstitium. We have finished with classic distribution of some patterns of ground glass. Okay, now going back to cysts again, we have the classic subpleural predominant clusters of cysts in honeycombing, and the classic upper lobar bizarre shift of pulmonary Langerhans, and the classic diffuse cysts in both lung with an otherwise normal lung in females with LAM. Now in this case, what do we have here? We have a diffuse bilateral disease. If you look at the unit of lesion in the image here, in the magnified image, we'll see that the lesions are tiny, dense nodules. Now, here, if we also look at the PA film, you find that you cannot find the end of the lung. There is hyperlucency going on until the end of the film on both sides, with ill definition, total ill definition of the diaphragm, total ill definition of the heart. Okay? This appearance with hyperlucent lung, with miliary appearance of relatively dense nodule, with ill definition associated with ill definition of heart, hilum, and of the diaphragm, is a spot diagnosis for pulmonary alveolar microlithiasis. Okay, so and this is called the sandstorm appearance. You don't diagnose microlithiasis just by seeing what you think as dense nodules. It might be a fallacy, by technical fallacy of the film. You have to see ill definition of heart, ill definition of the diaphragm, and hyperinflated lungs. The lungs are hyperinflated. They are actually increased in volume. Okay, so this is pulmonary alveolar microlithiasis. It is a rare entity. Okay, and most of the time it's of unknown cause. Some people have suggested a few years ago that it may be some sort of familial, but it's not. It hasn't been proved. Now, what again, we have a diffuse bilateral disease showing the classic crazy paving. أكيد كلكم بقيتوا عارفين المنظر crazy paving. Crazy paving is what? Is summation of three things. We have ground glass, and through this ground glass we see prominent interstitium. This interstitium actually is prominent inter and intralobular. So ground glass with prominent inter and intralobular interstitium, this is crazy paving. But in this case, this crazy paving is geographical. And it is very sharp demarcation between the lesions and the normal lung. This demarcation here, okay, will actually represent what we call pulmonary alveolar proteinosis. Now going to small and large airway disease. Small and large airway disease. Here we have the signet ring sign. What is this? Now we have the bronchus and the artery side by side, and they are nearly the same size. Okay, when the bronchus is larger than the adjacent artery, this is a signet ring sign, and this equals an early sign of bronchitis. Later on, as you can see here, this large airway disease with bronchiectasis, okay, cystic and fusiform. And if you look at the lung surrounding it and on the other side, you will find what looks like mosaic pattern with a normal lung being white and the abnormal lung avascular and black. And this is classic for bronchiolitis obliterans, which is usually associated, which is a usual association with of bronchiectasis. Okay, it's a small airway disease, usual association of bronchitis. So as you can see on the right side image, we have tubular bronchiectasis on the left lower lobe. We have fusiform bronchiectasis on the right lower lobe. We have cystic bronchiectasis mostly in the middle lobe, and we have early ring signet ring sign in the left lower lobe. Now again, we have seen this before. This is cystic bronchiectasis, and to remind you, this is cystic bronchiectasis because we have cysts surrounded by marked oligomere. Going to the small airway. Small airway are bronchioles. What are the possible lesions that we meet? The commonest actually we meet is traction bronchiolectasis. Bronchiolectasis mean widening of the bronchioles. We don't normally see the bronchioles, okay? We only see diseased bronchioles, okay? The commonest is traction bronchiectasis. As you can see here, there is interstitial fibrosis, and those lucences, linear lucences within, are dilated bronchioles. So the bronchioles are seen here because they become larger due to dilatation. Bronchioles may also dilate in case of infection. It's not common, but it is seen. In this case, we have the peripheral linear structure. Peripheral linear structure are not bronchi, they are bronchioles. They are visualized because of two things. They are dilated, so there is bronchiectasis, and they have a thick wall, so there is peribronchial thickening. This is a case of tuberculosis, and as you can see here, there are the bronchial thickening and dilatation. Now this is the very famous tree in bud pattern. What's tree in bud pattern? You see nodules, dots, and some of them you will come to see branching, having a V shape, a Y shape, their branch. This branching pattern, which is peripheral, as you can see here, basally, is a tree in bud pattern. It means this is cellular bronchiolitis, meaning that the bronchioles become filled by something. It is no more black inside. This happens in tuberculosis. It can happen in other types of infection. It can happen in aspiration bronchiolitis, aspiration whatever. Okay, it sometimes happens associated with bronchiectasis. These are cellular bronchiolitis, and this is tree in bud. And another case of tree in bud, if you look, there is nodules, there are dots, and peripherally they are branching. This is the tree in bud pattern in case of TB. Again, emphysema is a small airway disease, don't forget this. And here we have on the left side, the central lobar emphysema, holes without walls affecting the upper lobes. On the right side, we have holes without walls and peripheral bulla and bleps, paraseptal emphysema. Now here we have on the left side, we have on the right lung central lobular emphysema, and in the left lung, as you can see, there are marked hyperlucency affecting the whole of the secondary pulmonary lobule. You can see the wall of the lobule now. Now, this is severe central lobular emphysema, and it may be considered by some as a pan-acinar emphysema. But so as not to have a confusion, the real pan-acinar emphysema starts as such. It's lower lobar predominance, and it is caused by alpha-1 antitrypsin deficiency. It's a rare entity caused by alpha-1 antitrypsin deficiency. It's usually come in elderly patient. He comes with severe dyspnea because of the severe pulmonary hypertension that is associated. So as you can see on the left lung, this is the whole lobule affected by emphysema. Now I find associated lesions. In this case, for example, in the heavy smoker, we have the central lobar emphysema. Central lobar emphysema is a smoking-related emphysema. While basally, we have bilateral, fairly symmetrical, subpleural, or actually predominant lower lobe affection, with pleural recess affection, decreased volume of the lower lobe, and traction bronchiectasis and bronchiolitis. We have interstitial fibrosis. This actually form a disease entity which is not uncommon nowadays, which is called combined pulmonary fibrosis and emphysema, CPFE, combined pulmonary fibrosis and emphysema, and it's a smoking related disease. Also here we have another patient who is a heavy smoker. We have centrilobar emphysema, which is marked in the upper lobes, bilateral effusion, relative cardiomegaly, and if you look basally, you will find prominent interlobular septa with the bilateral effusion. You will find fissural effusion. This patient has combined pulmonary fibrosis, pulmonary emphysema, and interstitial edema. Finally, we come to the pleural lesion. We will summate all the pleural lesions that we have passed, and we'll see some mucus. This is opaque hemithorax contralateral shift. This is plain X-ray, PN lateral of massive effusion. This is a CT of massive effusion with relaxation collapse, contralateral shift, and a free effusion on the left side. As you see, I said before, if you see a concave upper margin of the effusion, which is parallel to the rib, this means I'm dealing with a free effusion. Now, here also, we have bilateral pleural effusion. Also, there is a pericardial effusion. The effusion in both cases is parallel to the rib. The anterior margin of the effusion, of the margin of the effusion, is parallel to it's concave. So this is a free effusion. In this case, however, on the right side, you will see a convex margin of the effusion in the lung window. This effusion is not parallel to the rib no more, so this is a loculated effusion. While on the left side, it is still parallel to the rib, so it is a free effusion. So we have loculation of the effusion on the right side and a free effusion, which is moderate effusion on the left. Now here we have two images of the same patient. Of course, the right side image, as you can see, have loculation, which is so clear, and even a dense pleura, while the remaining of the effusion basally is free. And this is something that you see a lot, partial loculation of an effusion, partial loculation. And here we have a contralateral shift of the mediastinum. Mark you, if you have total loculation of the effusion, even if it is a massive one, you will not have mediastinal shift, considerable mediastinal shift. Now here we need to differentiate between effusion and ascites, the four signs that differentiate effusion and ascites, as you see them here. The crura sign, and effusion will be medial to the ascites, this is crura sign. Medial to the cupula, this is crura sign. Posterior to the cupula, this is the diaphragm sign. It will fill this region, which is supposed to be the bare area. In case of ascites, bare area has no water. And finally, the interface sign. In interface, look here, this is ascites. Look at the interface between ascites and liver. The interface is so sharp, while the interface between effusion and liver is very vague. So this water here is effusion, while this here is ascites. These are the four signs that differentiate effusion from ascites. Now here, what do we have? This is a scanogram in a case of pneumothorax. Look here, this is a normal costophrenic angle, while this is a deep costophrenic angle, a sign that we call deep sulcus sign. This is how we see pneumothorax in a supine patient. It's extremely important to know how to diagnose pneumothorax, hydropneumothorax, and effusion in a supine patient, because actually this case will happen in a case of trauma, in a case of post-operative, in a case of patient with ICU. All of these patients cannot stand. And if you don't diagnose such entities in those patients, you will miss and you will cause marked harm to the patient. This is a deep sulcus sign where we have a very deep going down costophrenic angle. And this is how we see the pneumothorax in this patient. Now this is another patient, supine patient. This is a film paper, of course, the image from a paper. That's why it's not very nice. This is a normal costophrenic angle. This is the deep sulcus sign, and the patient also has surgical emphysema, as you see here. Another supine patient, and here the lesion is, this is the normal. This is the deep sulcus sign, and it's even on both medial and lateral, deep sulcus sign. And this is the clear diaphragm sign. But mark it, take care here. because you will have the same impression on the other side. You may have an impression that you have a clear diaphragm sign, so don't depend much on this sign. The most important sign to diagnose pneumothorax in a supine patient is the deep sulcus sign. Okay. Now here, this is a bulla and this is pneumothorax. See the bulla, you see it actually as a black mass, while pneumothorax will displace the lung as it is. It only displaces the lung. It does not indent it as the bulla does. Okay. Here we have a tension pneumothorax. Now tension pneumothorax here has caused marked collapse, marked contralateral mediastinal shift, and congestion of the other lung. So as I said, it's a fatal condition. It should be managed immediately. What we have here is a loculated pneumothorax, multiloculated pneumothorax, as you can see. Pneumothorax should have a deep sulcus sign. This is jet black, so this is air. Air should not be seen laterally. If there is air, it should be normally medially and inferiorly, not laterally and superiorly. If we see air in abnormal position, even from this scanogram, it suggests I have loculation. It's not free to go. What do we have here? We have a deep sulcus sign, a clear diaphragm sign, and in the same time we have veiling and we have capping. So we have actually a hydropneumothorax, air and fluid. We have bilateral here, loculated, multiloculated actually, because more than fluid level is seen. Bilateral multiloculated hydropneumothorax, and in this case we have intercostal tubes, so we will not consider the possibility of a bronchopleural fistula. As I said before, if we see a loculated hydropneumothorax related to an inflammatory lesion, okay, we have to consider a bronchopleural fistula, especially if there is no tube put. Here we have a bronchopleural fistula. There is marked pneumonia, complicated, and a loculated hydropneumothorax without a tube. This is a fistula, bronchopleural fistula. Now we have pleural thickening and fibrosis of the lung, decreased volume. This is a case of fibrothorax and cicatricial collapse of the lung. This is a case of localized thickening of the pleura, fibrothorax that is localized with intense calcification with decreased volume of the hemithorax, right lung. Another case with fibrosis, decreased volume and calcification, and as I said, we have seen this before, this is round atelexis. Okay, now we have bilateral pleural plaques here. Okay, this is a case of asbestos exposure. Some of them show mild calcification, and this is the comet tail sign that you heard of, and this is diaphragmatic calcification. Another case where bilateral plaques are seen. Some of them show dense calcification. Bilateral plaques are sign of asbestos exposure, not asbestosis. Asbestosis is an interstitial disease causing by prolonged exposure and working in a factory of asbestos, while asbestos exposure can happen to any person in the vicinity, okay, of asbestos manufacturer, asbestos factories, okay. It's common in some parts in our country, especially Helwan and Badrashin and so on. You see these, they mean nothing. They are not interstitial fibrosis. They are only pleural plaques. It is called asbestos exposure, okay? It is associated with, maybe associated with other lesions later on, but by itself it is not. Bilateral pleural plaques with calcification and diaphragmatic calcification is asbestos exposure. Okay, and this is how they will look like in the scanogram. You see here. Now here we have circumferential nodular thickening on top of an asbestos exposure. Now this will suggest that we may have a mesothelioma. Here on the other hand, we have the typical appearance for a radiologist of a mesothelioma, which is circumferential nodular thickening of the pleura. Okay, this is a mesothelioma. Another appearance, nodular appearance with decreased volume. By the way, a mesothelioma may be associated with decreased volume, and this is a classic pattern, or a normal volume, or even an increased volume if it is associated sometimes with a mass effectant effusion. So the volume change has nothing to do with it. If it is decreased volume, it is more pathognomonic. Circumferential nodular thickening associated with effusion. Now, mesothelioma may be associated with such strange patterns of calcification, okay, globular calcification, and this is osteocartilaginous differentiation in mesothelioma. This is a focal area of mesothelioma actually, and this is globular calcification. This is another case of mesothelioma with fissural affection, and again the calcification, this has nothing to do with asbestos. This globular calcification is a lesion by itself in the mesothelioma, and it's called osteocartilaginous differentiation, and it could be very massive, as in this case. In this case of mesothelioma, you can see the affection. The whole mesothelioma has shown this pattern of osteocartilaginous differentiation, and even the fissure is affected. Now, having a mesothelioma, we have to comment on, and we have to look at the mediastinal infiltration, the chest wall infiltration. Okay, here we have a case of mesothelioma infiltrating the pericardium, the heart, and the mediastinum, as you can see. And the differential diagnosis of such thing is metastasis to the pleura. In this case, we have non-small cell lung cancer metastasizing to the pleura. We have pleural metastasis here, okay? And in this case, we have, as you can see, bilateral prominent interlobular septi. This was a case of cancer stomach with lymphangitis carcinomatosa and bilateral pleural metastasis. Thank you very much. I have finished my lecture, only 5 minutes late. Alhamdulillah, Rabbana sah. Thank you all very much. Thank you, Professor Hisham, very much for everything. It has been a great pleasure being with you, sir.
Thank you very much. Our great Professor Dr. Yosryah, a very long day and very good effort. And now I have 3 questions. The first one, how to differentiate cicatricial fibrosis and cavitary collapse and honeycombing.
ده حد كان حاضر المحاضرة؟
ده هو ده سؤال دلوقتي.
طيب نكتب مع حضرتك. طيب السيكاتريشيال كولابس، تمام مظبوط كده. ده أول مع إيه؟ مع كافيتي.
كافيتيتنج كولابس اند honeycombing.
طيب أول حاجة الكافيتي ما هياش كولابس. الكافيتي ده ليجن، ممكن الليجن ده يبقى ماس، ممكن الليجن ده يبقى نودول، ممكن يبقى كونسوليديشن او اوباستي في اللنج. جوه هذا الشيء سواء ماس ولا نودول ولا اوباستي بلاقي خرم اسود جوه الليجن. This is what we call a cavity. تمام، بس مش اكتر من كده، بلاقي حاجه جواها خرم يبقى ده كافيتي. ستيكاترايزيشن انا المنظر عباره عن فرح، يعني لوسنسز كتيره وستراندز كتيره، تمام اوكي، معاها فوليوم لوس. اوكي، يبقى انا امتى هقول على الفرح ده؟ يعني هستأذن حضرتك في سبليت سكرين تاني هوري الصوره لو كان ينفع.
اتفضل.
ما انا مش عارفه اعملها دي.
استاذ ابراهيم
يعني اوكي طيب هنعمل هنا كده.
تشير المحاضره تاني
لا هجيب بس الصوره بتاع السيكاتريشال كولابس. طيب اول عشان لقيناها في السكه بس اهو. ده الهاني كومبينج. ايه اللي بشوفه في الهاني كومبينج؟ لازم الاتي الشروط الاتيه عشان اقول ده هاني كومبينج. ان انا ما بشوفش سيست، بشوف كلاسترز اوف سيست مكانها سب بلورال وبيزل بريدومينانت وفيلينج ذا بلورال ريسيس. يعني اهو يبقى شكلها عامل ازاي؟ كلاسترز اوف سيستس تمام جنب بعض، مفيش حد فيهم يقدر يقول دي الوول بتاعتي، تمام، ومكانهم لازم سب بلورال ومكانهم السب بلورال ده اكتر حاجه تحت وفيلينج ذا بلورال ريسيس. يبقى ده منظر الايه؟ الهاني كومب، وهو بيبقى بايلاترال وفيرلي سيمتريكال بيكوز ام ديلينج وذ ان انترستيشال ديزيز. يبقى طلعنا الهاني كومبينج من الحكايه كده بايلاترال فيرلي سيمتريكال سب بلورال بريدوميننتلي بيزل كلاسترز اوف سيست. نطلع من دي ونشوف بقى ايه. مش عايز اطلع يعني، مش عايز يعمل اسكيب، علق معايا. الو
ايوه يا دكتوره اتفضلي.
مع بتاع لا ثانيه واحده دي نشوف. طيب نيجي بقى ايه لللوبر كولابس او للكولابس سيكاتريشن اهو. طيب المنظر ده بقى عامل ازاي؟ اول حاجه اللي هو اللي كلم اتلخبط انه يقول ان ده كافيتيشن، جميل حقه تمام، بس تعالى نشوف مع بقيه الحاجات. الحدوته ان انا عندي مالتيبل لوسنسز وحاجات بيضاء مع كافيتيشن. الدكتوره يسريه لا بص معايا بقى حضرتك، انا عندي ايه حصل؟ الليجن ده عمل ايه عشان اقول عليه كولابس؟ انا امتى بقول كولابس؟ لما الليجن بيشد الحاجات اللي حواليه، فهو هنا شادد الميدياستاين تمام. فانا عندي predominant blackness اولا، مش predominant white lesion، يعني انا عندي خروم اكتر من الايه من الابيض. ده حاجه. الحاجه ان ده شد الايه، شد الايه الميدياستاين. لما نيجي للي بعديه، هل انا عندي هنا ايه؟ ليجن ابيض في اسود تمام، والليجن الابيض في اسود ده شد الفيشرز بقى سيكاتريشال كولابس. هنا عندي ليجن ابيض في اسود عمل ايه؟ شد الفيشرز، يبقى ده بقى اسمه سيكاتريشال كولابس برضه. والدليل على كده ان احنا لما جينا نوصف هذا الليجن هنا قلنا ان انا ادي ده سيكاتريشال كولابس عشان شد الحاجات، ونفس المنظر اللي تاني بالظبط لكن عمل ماس ايفكت تمام. فده قلنا عليه ايه؟ عمل ماس ايفكت. فده قلنا المنظر ده اللي هو ابيض في اسود والاسود دومينيتنج تمام. انا ما اقدرش اقول هنا ان في حاجه مخرمه، الاسود هنا مور اور ليس دومينيتنج، ما علينا يعني. لكن المنظر ده كونجنتال بالمونري مالفورميشن تمام. فانا ما ببصش على حاجه واحده، انا ببص على الحدوته كلها. اوكي، عندي لوب كله ابيض في اسود ومعاه فوليوم لوس، ده سيكاتريشال كولابس. عندي هنا معايا سعادتك
ولا الاستاذ ابراهيم بعد اذنك بس يا دكتوره يسريه هيشير الحاجات اللي حضرتك بتعلقي عليها الصور.
طيب يا فندم.
لان الصور مش ظاهره لهم دلوقتي.
طب ما ينفعش نعمل شير سكرين تاني بيه عشان الناس تفهم بس؟
ده شير سكرين تاني.
طيب هنا برضو ده كافيتي. ليه قلت ده كافيتي؟ انا عندي ليجن ده ماس، وجوه الليجن ده there is a hole. طيب احنا وصلنا للكافيتي. تمام كده حضرتك. لحظة واحدة. بدأ سوري. ادي الكافيتي خلاص. فاحنا كده عملنا ايه حضراتكم؟ احنا الكافيتي ليجن مخروم. عندي انا ما اعرفش بقى يعني، هقول من الاول كل اللي فات ده. ماشي.
على يعني حاجه على قد السؤال بالظبط بس كده.
طيب على قد السؤال بالظبط. ليجن فيه خرم، ده كده المنظر بتاع الكافيتي. الليجن اللي هو حضراتكم فيه فوليوم لوس وقلوب معاه فوليوم لوس، ده السيكاتريشال كولابس تمام. لو لقيت الليجن كلاسترز اوف سيستس كتيره جنب بعضها، مفيش ستراندز هنا خالص، ده سيست جنب سيست جنب سيست جنب سيست، ده الهاني كومبينج، they share the wall تمام. الكلاسترز اوف سيست اللي هي سب بلورال وبايلاتر وفيرلي سيمتريكال وبريدوميننتلي بيزل وفيلينج ذا بلورال ريسيس، ده الهاني كومب بس، منتهى البساطه. يبقى كافيتي في ليجن ده كافيتي، loss of volume ده السيكاتريشال كولابس، بايلاترال فيرلي سيمتريكال سب بلورال بريدوميننتلي بيزل، ده الهاني كومب. تمام يا فندم؟
طب دكتوره يسريه، طيب انا هستاذن حضرتك بس تشير السكرين عشان
طيب انا اعمل ايه؟ انا فاتحاها مش عارفه اعمل ايه. طيب انا يعني المفروض اتك على حاجه عندي؟
في سؤالين تانيين. زي ما حضرتك
شير سكرين. انا بيديني disable يا فندم. host disable participant screening. مش عايز يديهاني ساعتك، مش عارفه يعني. بص ما انا بضغط على الشير سكرين اللي هي الاخضر ده، مش عايز يفتحني. والله يا فندم وحياة ربنا مش عارف اعمل ايه. طيب الباوربوينت مفتوح ورا الصورة اللي قدامي، ورا دلوقتي هو مش جايب قايمة، هو لما بتك على شير سكرين بيديني هوست ديسيبل بارتيسيبانت سكرين، ده اللي طالع زي قلت اوكي يا فندم بيرجعني تاني ما بيفتحش هوست ديسيبل. حضرتك اللي طالع عندي هوست محمود دالاس از هوست ناو. هشام الدكتور هشام الشيخ هوست، انا ديسيبل يا فندم ام نوت ا هوست. هو ما بيفتحش عندي يا حبيبي والله، والله عمال اجرب يعني، انا عمال اجرب ساعتك مش فاتحني انا يعني شير سكرين بيقول لي ديسيبل. حضرتك هوست وبعدين دكتور هشام هوست ام نوت ا هوست. لسه هوست ديسيبل بارتيسيبانت سكرين شيرنج يا فندم لسه. هصورها لك يا ابني وابعتها لك لحظة واحدة. ده المنظر اللي عندي. طيب اوكي كده جاب ابتدى يظهر عندي تمام كده انا اوكي يا راجل. طيب ماشي. طيب ايه السؤال دلوقتي يا باشا؟
طيب another question دكتورة يسرية is there is another is there is a diagnostic feature for كابوسي sarcoma؟
اللي انا قلتهم يا فندم هجيبها لحضرتك تاني، هو اللي انا قلته ده بالظبط هي الدايجنوستيك فيتشر بتاع الكابوزي. بس اهم حاجه في الكابوزي ان حضرتك تكونسيدر في الدايجنوز من الاول، يعني لازم ابقى في حته انديميك او عيان اميون كومبرومايزد ماركلي عنده ايدز وات ايفر. لحظه واحده سعادتك اهي الفايندنجز اللي described في الحاله دي are typical of كابوس. نمره واحد الirregular large nodules دول بيتسموا flame shaped nodules. This is number one. Number two, some of the lesions will have ground-glass opacification surrounding them. Number three, some nodules are lying on the fissure. اوكي زي ما حضراتكم شايفين هنا. Or have pleural base. نمبر 4 اللي موجود حضرتك ان الايه في prominent bronchocentric interstitial اللي هي الحاجات اللي ايه البرونكاس والارتري اللي جنبهم شكلهم prominent. فتاني الفليم شيبت اولا bilateral lesion flame shaped large relatively large nodules. Some of the nodules are pleural based that are related to the fissure and the pleural periphery. اخر حاجه ان في prominent bronchocentric interstitial. فين افكر في ده فين؟ يعني لو شفت ده في حته ما هي مش في دماغي او ما فيهاش كابوزي تمام، ده شكلها حاجه انفلاماتري بس هقلق تمام. لو انا بتعامل في حتى انديميك في يعني الكابوزي ده بيبقى فيه سبوراديك كيسز وانديميك كيسز وابيديميك وهيصه كده. الانديميك ارياز زي سنترال وايسترن افريكا تمام، ده انديميك كيسز اوكي. عيان بيجي برضو للعيانين الترانسبلانتيشن ده الياتروجينيك تايب. يبقى لو انا عارفه ان عيان ترانسبلانتيشن this is one of the complications اللي هقلق منها المنظر ده. عيان جاي من انديميك اريا، عيان باميون كومبرومايز سبيشالي لو ايدز او عنده هيربس انفكشن والكلام ده. فده العيان اللي هحط في دماغي ان إيه لازم ابقى قلقانه من this possibility مع التيبيكال 4 حاجات اللي احنا قلناهم دول: bilaterality, flame shape, pleural base, ground glass opacification and prominent interlobular interstitial. كده 5.
Okay, the third question دكتورة يسرية is there is a definite science to differentiate subacute hypersensitivity pneumonitis from COVID-19 on a radiological basis alone؟
نقول كمان لحظه واحده فهمت. في حد هيشخص المنظر ده كوفيد؟ الو.
ايوه يا دكتوره يسريه اتفضلي.
وصلنا لفين يا فندم قبل ما يقطع؟ حاضر يا حبيبي. disable تاني. ايوه تمام. اوكي تمام. تمام يا استاذ محمد. استاذ محمد اللي معايا ولا مين؟ تمام يا باشا، ميرسي سعادتك، شكرا. فالمنظر اللي قدامنا ده حضرتك، انا عندي bilateral diffuse ground glass with intervening lucences ما فيهاش vessels، وintervening lucences بتعريفه فيها شويه normal lung marking. again هذا الديفيوز appearance bilateral diffuse appearance ده مش منظر من مناظر الكوفيد خالص. الكوفيد بيبقى باتشي جراوند جلاس، مش الجراوند جلاس هو اللي ملك الدنيا وانترفيننج موزايك برفيوجن. مفيش موزايك برفيوجن في الكوفيد اصلا. ما علينا يعني. الكوفيد بشخصه ازاي؟ الكوفيد اي منظر قدامي، اي منظر بشوفه في السي تي، البوسيبيليتي ان ده انفكشن، بغض النظر بقى عن الكلام اللي كان بيتقال اول تيبيكال واتيبيكال بقى، اي منظر ممكن يبقى انفكشن اي كونسيدر كوفيد. بمعنى البريفرال كلاسيك بريفرال ليجنز بتاع جراوند جلاس والكونسوليديشن وبتاع، او الباتشي areas of consolidation او patchy area of ground glass، او موزايك وباتشي باتشي وبريفرال. لكن ان انا عندي diffuse ground glass بهذا المنظر وintervening hypo perfusion areas، this is not a pattern of cough، لانه مش pattern of inflammation اصلا. تمام.
Okay, Dr. Yosryah. And a third question: how to differentiate asbestos exposure from osteochondrogenic mesothelioma? I am just
اللي هقول حضرتك برضه هو ايه بمنتهى البساطه، هي الحاجات فيها شبه، بس يعني ببقى very precise وانا ببص منتهى. انا فصلت انا فصلت تاني مش عارفه ليه. اوكي I think I'm back. اوكي نبص حضراتكم مع بعض كده على الشاشه ان شاء الله عشان المقطع وحشه مش معلق. اوكي let us go to the pleural. نبص على الايه الاسبستوس. بصوا حضراتكم معايا، ادي منظر البليتس بالكالسيفيكيشن بتاع الاسبستوس اكسبوجر بايلاترال، ويعني يا اما بتبقى دوت يا اما بيبقى لينير ستراكشر زي ما حضراتكم شايفين كده. ده منظر الكالسيفيكيشن في حالات الاسبستوس مع البايلاتراليتي. طيب نيجي نبص بقى هنا في حاله الايه الاوستيوكارتيلاجينس ديفرنشيشن. زي ما بقول لحضراتكم ان الكالسيفيكيشن هنا، هل ده دوت؟ لا، ده كونجلوميريت كالسيفيكيشن. ده كونجلوميريت كالسيفيكيشن، بوتشت كالسيفيكيشن محترمه موجوده اهو هنا في اللانج ويندو اوضح. كونجلوميريت كالسيفيكيشن موجود. اللي بعدها كونجلوميريت كالسيفيكيشن، ده مش لينير كالسيفيكيشن ولا دوت بنت ناس كده موجوده بريفرال، ده كونجلوميريت كالسيفيكيشن. وطبعا الحاله الثالثه يعني ده مش ممكن يعني ده كده يعني ما بقاش في ميزوثيليوما اصلا. It is a total differentiation هنا للاوستيوكارديولاجينس تايب. تمام؟ فالباترن اللينير، الباترن الرفيع، الدوت، البايلاترال غير المنظر الكورس ابييرنس، كورس كالسيفيكيشن بتاع الاوستيوكارديولاجينس كالسيفيكيشن. تمام؟ اي فندم.
Another question, دكتورة يسرية, how to differentiate cicatricial fibrosis from honeycombing.
قلنا ده وهي ما فيش حاجه اسمها سيكاتريشال فايبروزس. يعني هي سيكاتريشال معناها فايبروزس، هي سيكاتريشال كولابس. تمام؟ السيكاتريشال كولابس تاني بيبقى لوب اوكي ماركت بفوليوم لوس. الهاني كومبينج bilateral fairly symmetrical subpleural predominantly basal with filling the pleural recess of clusters of cysts, total different appearance.
Okay, emphysema and lymphangiomatosis, I think differentiation.
غالبا يعني ساعات بيبقى الفكره كلها ان انا عايزه افرق ده يعني ده emphysema ولا ده سيست بمنتهى البساطه. تمام؟ افرق ازاي؟ افرق بان انا بدور على وول. ده واحد. نرجع هنا كده. المنظر هنا زي ما حضراتكم شايفين خروم سوداء وupper lobar predominance. خروم سوداء، اللنج هايبر انفليتد وهايبر لوسنت، والتراكيه فيها ساينز اوف سي او بي دي اللي هي سابرشيس تراكيه، وفي هايبر انفليشن في اللنج، وجوه كل ده في holes without walls that are upper lobar predominant. تمام؟ طيب امال الثانيه بقى عباره عن ايه؟ الثانيه عباره عن cysts اللي هي ايه بالظبط يعني؟ cysts. والسيست دي ما فيش سايت اوف بريديلكشن، بيأفكت من فوق لتحت. اوكي؟ في upper lobe وميدل ولور وكل حاجه. cysts all through a wall is so clear as you can see here. تمام؟ فده منظر مختلف تماما. الانفيزيما السنترال لوبير بتبقى خروم وupper lobar predominance، وغالبا بيبقى في other signs of COPD hyperinflation وhyperlucency وبرونكيال wall thickening etc. هنا مفيش سايت اوف بريديلكشن الناحيتين. in addition وده حاجه مهمه جدا I'm dealing غالبا most of the time يعني more than حاجه 90% with a female in the childbearing period. يعني اللام is classically affect females in the childbearing period. دي برضو دي important ده. يبقى اللام بيبقى الوول اهو واضح بتاع السيستات، وهذه السيستات بتبقى all through the lungs in a female with a childbearing period. وستيل برضو من باب الانصاف sometimes ساعات بيبقى لو يعني الكواليتي بتاع السي تي ما هوش كويس قوي sometimes it is difficult to differentiate. So I stick to all the points. بدور على distribution. لو لقيت الليجن اللي انا بتعامل معاه upper lobar predominance يبقى انا في سكه الانفيزيما. لو الليجن ديفيوز يبقى انا في سكه ان انا مش متاكده من الوول بس الليجن ده ديفيوز وابر ولور وبنفس الدنسيتي وبنفس الانتنسيتي ويبقى انا بتكلم على لام. زي ما بقول لحضراتكم عشان افرق حاجه من حاجه ما ببصش على نقطه واحده، ببص على الحدوته على بعضها. انا ده له وول، طب انا مش متاكده ان في وول، طب في ديستريبيوشن وفي جندر بريفرنس، كل ده بيتحط مع بعض.
Another, I think this is an easy question. How can identify a central mass in totally collapsed lung?
طيب بالسي تي ولا بلين اكس راي؟ بالبلين اكس راي مش هشوف. يعني الا بقى لو واحد مكشوف عنه الحجاب وبينه وبين ربنا عمار وحاسس بقلبه ان في ليجن جوه. بالستي بمنتهى البساطه، بمنتهى البساطه الماس ده هيبقى ديماركيتد من اللي حواليه، يعني هو هيبان لوحده كده، هيبقى ديماركيتد من اللي حواليه ان في جوه الوسعايه دي في انذر ليجن. لو مش باين، وده بيحصل بقى في السنترال ماس مع كولابسد، اللي هو لو ده اللي هو يقصده يعني لو انا عندي برونكوجينيك كارسينوما وجنبها كونسوليديشن او كولابس في اللنج، لو ده السؤال المقصود. ده طبعا central bronchogenic carcinoma is a mediastinal lesion by the way, it is not a lung lesion بالمناسبة، هي بتعمل lung changes. طيب نيجي بقى انا هفرق ازاي؟ مش هفرق بمنتهى البساطة. plain x-ray I will not be able to differentiate. السي تي في بيقول لحضرتك ادي مش عارفة كام امبول صبغة، فلما تدي كام امبول صبغة الليجن هيبقى enhanced واللي حواليه مش هينهانس. الكلام ده كلام غالبا ما بيفرقش، يعني actually speaking مش هيبان. طيب ايه تاني ممكن بايه بقى نفرق؟ ممكن نعمل بيت، ده هيفرق. ممكن نعمل حاجات فانكشنال ايمجنج، نعمل ديفيوجن ار، ده هيفرق وهيبين الانفلتريشن. خلاص، يبقى بالموداليتيز العاديه اللي هي السي تي العادي حتى بالصبغه والبلين اكس راي انا مش هفرق. عشان افرق سنترال ماس عامل اوبستراكشن ونتيجه لهذا الاوبستراكشن في كونسوليديشن في لانج كولابس او كونسوليديتد او وات ايفر لانج لازقه في هذا الماس، الحل الوحيد ان اعمل يا بيت سي تي يا اعمل ديفيوجن ايمج.
Another question: how to suspect atypical infection on I think this an X-ray or CT atypical infection.
طيب هوريكم حضرتك، هرجع لحاله هنا كده وهقول لحضرتك امتى consider atypical. Let us see here. نبص على الحالة دي. This was atypical infection. يعني ايه atypical؟ يعني not typical. طب ايه هو التيبيكال؟ هو ايه اللي انا بشوفه في الانفكشن؟ بشوف ممكن لو هي جايه باي بلاد بورن بشوف نودولز وكافيتيتنج نودولز. لو هي جايه ثرو ذا اير بشوف الباتشز بتاع البرونكونيمونيا اللي هي شفناها في كذا حاله وريناها. طيب لما الاقي منظر زي ده كده، يعني بصوا حضراتكم على الصوره اللي على الشمال، بصوا الكافيتي شكلها عامل ازاي، بصوا على الليجن في اللنج الشمال في الصوره اللي فوق، ايه المنظر ده؟ بيزار ابيرنسز كده، وكافيتي شكلها غريب وليجن شكلها غريب. ده المنظر اللي بيسجست ان ده انا بتعامل مع حاجه اتيبيكال انفكشن. تمام، يبقى ايه ما هياش نودولا بنت ناس، ولا هي كافيتيتنج نودولا بنت ناس، ولا هي باتشي اوباستي عاديه، لا ده منظر كافيتي شكلها غريب. ومنظر ممكن الاقي كمان الريفيرس هيلو ساين، ده برضو اتس نوت تيبيكالي، يعني ده لو بصيتوا هنا على اللنج الشمال هتلاقوا حاجه ممكن تبقى ريفيرس هيلو، يعني دنسيتي اعلى من بره وجوه ريلاتيف جراند جلاس. الكافيتيشنز شكلها كومبلكس على الناحيه اليمين في الصوره الفوقانيه. فكل ده مش منظر تيبيكال. المنظر التيبيكال الطبيعي الاقي نودولز او كافيتيتنج نودولز لو هي بلاد بورن انفكشن، او الاقي باتشي برونكونيمونيا سنترال واير برونكوجرام والكلام ده لو هي ايربون. لكن الاقي كومبلكس كافيتيشن وريفيرست هيلو والاقي نودول شكلها irregular وبيزار، كل ده مع ان انا هفكر في ان ده اتيبيكال انفكشن. اتيبيكال انفكشن ده افكر في ايه بقى؟ والله العيان غالبا بيبقى اميونو كومبرومايز واي اور انذر، بياخد كورتيزون، عنده سكر جامد مش كنترول، العيان لسبب او لاخر عامل ترانسبلانتيشن وات ايفر، كل هذه الحاجات رينال فيلير، الكلام ده كله، كل الحاجات دي هتخليني اكونسيدر ان ده اتيبيكال. يعني ايه اتيبيكال؟ يعني كوزد باورجانيزم مش العادي اللي بنتعامل معاه، مش نيمو والكلام ده، مش بتاع، بنتعامل مع فانجس، بنتعامل مع فيرال، بنتعامل مع وات ايفر، كل ده كونسيدرد اتيبيكال. او بعض انواع البكتيريا اللي ما هياش الستاف والستريبتو والنيمو، اوكي، دول برضو بيدوني اشكال من الانفكشن شكلها غريب. بس يعني ديبيندز على شكل الليجن والعيان نفسه. العيان اميونو كومبرومايز باي واي اور اذر، رينال، كاردياك، كورتيزون، diabetes, transplantation, whatever.
The last question, Dr. Yosryah, how to differentiate between cavitating bronchogenic carcinoma and mycetoma fungal infection?
اوكي. المايسيتوما اصلا بتيجي مش يعني بتيجي فين؟ نبص كده حضرتك هنا ده كده ايه؟ طيب bronchogenic carcinoma that has cavitated. ايه اللي اتوقعه وايه المنظر اللي هشوفه؟ زي ما حضراتكم شايفين هنا هلاقي eccentric lumen بفلويد ليفل جميل، او من غير فلويد ليفل توتال ليومن ماشي، ونون يونيفورم وول، الوول الريجولار ونون يونيفورم. يبقى المنظر ده لما اشوفه كده عندي نون يونيفورم وول واليومن مرحله على ناحيه، في element of fluid level او مفيش وات ايفر. ده الكافيتيتنج برونكوجين. نيجي للمايسيتوما. لحظه واحده. نبص حضرتك هنا على الليجن اهو، في مايسيتوما. الوول اخبارها ايه؟ فيري سموث. اليومن سنترال وكريسنت شيبت، عامله زي الهلال، عامله زي المينيسكس. يبقى اليومن الاسود اللي عندي مينيسكال شيبت او كريسنت شيبت. سبب هذا الكريسنت شيبت ان في فيلينج ديفكت انسايد. تمام. هنبص برضو على منظر تاني حالا دلوقتي. يبقى انا عندي اهو سموث اوتلاين، تمام، و crescent shaped lumen وفيري يونيفورم. الوول الجزء اللي شايفينه از فيري يونيفورم. ده منظر المايستوما. المايستوما باي ذا واي ممكن تكون موجوده في اي كرونيك كافيتي، يعني ممكن تكون موجوده في كافيتي بتاع التي بي، ده اكتر حاجه بنشوفها. ممكن تكون موجوده في سيستيك فايبروزس، ممكن تكون موجوده مع ساركويد، ممكن تكون موجوده مع ماركت برونكايكتاتيك تشينجز. بس الشكل كلاسيكالي زي ما حضراتكم شايفين، الوول بنت ناس، الحته اللي احنا شايفينها، والاسود على شكل هلال. طيب هنبص على بلين اكس راي. لحظه واحده. هنا again this is a crescent sign. ادي الوول اهي، تمام، وادي اليومن منسكال شيب او crescent شيب. في convexity هنا في الكونتنت اللي جوه convex. تمام. ده منظر المنسكال ساين في الهايداتد. المنسكال ساين سواء في الهايداتد او في المايسيتوما، تمام، اللوسنسي كريسنت، الوول اللي احنا شايفينها فيري يونيفورم، والحاجه اللي جوه عامله كونفكس ابر، فيري سموث كونفكس ابر مارش which is totally different من المنظر بتاع الكافيتيتنج ماس. لما نبص كأن دي بلين اكس راي، ادي اماس وادي الكافيتي اللي جوه. الكافيتي اللي جوه اكسنتريك، الاوتلاين واليومن ثيك والريجولار، تمام، ومفيش اليومن موجوده مفيش فيها كومبلكستي مارجن ولا اي حاجه خالص. تمام؟ اي فندم.
Thank you very much, our great Professor Dr. Yosryah, for this long day and for these multiple lectures covering nearly all topics in chest radiology. We are greatly thankful to Dr. Yosryah for this very great effort. With another session of musculoskeletal imaging. Thank you for all. Assalamu alaikum wa rahmatullahi wa barakatuh. Assalamu alaikum يا دكتورة يسرية.
مع الف سلامه يا فندم، وسعدت بيكم النهارده.
شكرا جزيلا.
ميرسي يا فندم لسعادتك جدا.
شكرا جزيلا لحضرتك. شكرا جزيلا دكتورة يسرية.
ميرسي يا فندم. ميرسي لحضرتك. شكرا. مع الف سلامه.
ربنا يجزيكي كل خير.
ربنا يكرم حضرتك.
شكرا جزيلا.
ميرسي لسعادتك. ميرسي يا فندم. وعليكم السلام ورحمه الله وبركاته. الف سلامه يا فندم.